Supervisors workshop is 9. Clerk.
Supervisor Klein.
Here.
Supervisor Mulhern.
Here.
Supervisor Hashak.
Here.
Supervisor Norvell.
Here.
Supervisor Williams.
Here.
Okay, please stand for the pledge. I pledge allegiance to the flag. Okay, we have nothing under agenda review, so we'll go to public expression. You can either speak on anything non-agenda or anything that is on the agenda. Is there anyone in the room? Madam Clerk?
Seeing no comment online.
Okay, then we will get started with R1. We're going to go Office of Emergency Services. The presenters will be Travis Kilmer, and Garrett James, Jeff Adair, Jen Banks, Tammy Bartlome. And we'll start with R1, Disaster Mitigation.
Good morning, Chair Norvell, members of the board, CEO Ansel, and Interim County Counsel Elliott. My name is Travis Kilmer, and I serve as the Chief Recovery and Resiliency Officer for the county. I'm here today with Jeff Adair, our OES Coordinator, and Garrett James, our OES Specialist. Day to day, I oversee the Office of Emergency Services and support the full range of activities you'll hear about today. We're a 3-person team with a high level of cross-training, which allows us to remain responsive outside of normal business hours because emergencies do not follow a schedule. In addition to my operational oversight role, my position also includes responsibility for the county's long-term recovery and resilience efforts. That includes leading recovery and mitigation planning, directing damage assessments and continuity planning, and coordinating across county departments and with our external partners, all with the goal of reducing risk, strengthening our capabilities, and improving how the county responds to and recovers from disasters. The goal of today's presentation is to give you a high-level overview of OES, the work we do day in and day out, and how we support the county as a whole. Following our presentation, we'll be joined virtually by Ryan Aylward from the National Weather Service Eureka office, who will provide a winter weather outlook for the season ahead. To start, I'll walk through the core functions of the Office of Emergency Services, and the responsibilities that guide our work. Firstly, we manage the county's Emergency Operations Center. We ensure that the EOC is ready to activate at any time, and we work year-round with county departments and partners to maintain operational readiness. We also monitor weather, road conditions, and other potential hazards that could impact the county. This allows us to maintain situational awareness, coordinate with the National Weather Service and local partners, and begin preparing for conditions before they escalate. Planning is another key part of what we do. That includes developing, maintaining, and updating documents like the county's Emergency Operations Plan, the Hazard Mitigation Plan, and the Community Wildfire Protection Plan, along with reviewing and coordinating plans with local, tribal, state, and non-governmental partners. Finally, we manage mendoready.org, which is the county's central hub for emergency preparedness information, notifications, evacuation guidance, and recovery resources for the public. So these are the core functions that form the foundation of our work. Next slide, please. And now I'll touch briefly on how we carry that work forward through public outreach, mutual aid coordination, collaboration with operational area partners, and managing key state and federal grant programs. Public outreach is a big part of what we do. We use social media to share preparedness messaging and incident-specific updates, participate in community events like local fairs and Pumpkin Fest, and we maintain mendoready.org as the county's primary source of emergency preparedness and response information. When local resources are stretched, our office requests and coordinates mutual aid through state systems. We also monitor requests, help fulfill them when possible, and maintain memorandums of understanding with each of the county's 4 cities. During past large-scale incidents, we've submitted mutual aid requests to support response and sheltering operations. We also regularly facilitate coordination calls with operational area partners. These calls give agencies and jurisdictions a chance to share updates and raise any needs or concerns. We coordinate volunteer efforts through our work with VOAD to ensure that resources are used safely and effectively. OES also manages several key grant programs that directly support the county's emergency preparedness and response capabilities. These include the FEMA Emergency Management Performance Grant, multiple FEMA Homeland Security Grant Program awards, and a Department of Water Resources flood-related grant. The Emergency Management Performance Grant supports OES staffing through up to a 1-to-1 match of salary with local funds. The Homeland Security Grant Program provides critical funding not only for OES, but also for the Sheriff's Office, fire agency partners, and other local response agencies, supporting essential equipment, training, and capabilities, including the county's alert and warning systems. The Department of Water Resources grant is a one-time funding source focused on flood preparedness and mitigation. It's currently funding the development of a countywide flood response plan, along with pre-positioned flood fight materials in Point Arena, Copland, Ukiah, and Laytonville. These materials will complement DWR-owned flood fight containers already in place in Fort Bragg and Willits. So all of this work sets the foundation for the training, exercises, and systems that support our response when an incident occurs. Garrett James, our OES specialist, will walk you through that next, including our training and exercise efforts and the county's alert and warning systems.
Hello, I am Garrett James, Emergency Services Specialist. Day to day, my job focuses on plan creation and updates, creating training and exercises, public outreach and education, grants management, creating and maintaining strong relationship with operational area partners, and monitoring weather forecasts and for emergencies. During emergencies, I transition to assist with activation and management of the Emergency Operations Center, coordination with operational area partners, and provide subject matter expertise. I also focus on updating emergency maps on our website, mendoready.org, and providing technical support for dispatchers for alert and warning messaging. For training and exercises, OES staff provide regular training and actually, it's the previous slide. Yep. Sorry about that. For training and exercises, OES staff provide regular training and exercises to validate response plans, clarify individual roles, and build the synergy necessary for staff to perform under pressure. A few examples of training that we've completed is we've done an EOC specific training, or EOC section specific training for each EOC section. We've also provided alert and warning training for Sheriff's Office dispatchers. A few examples of exercises that we have completed are a full-scale EOC call center and ham radio activation exercise and call center and ham radio specific exercises. The Integrated Preparedness Plan is a multi-year training and exercise schedule that is a FEMA requirement for the Emergency Management Performance Grant. And OES staff is currently designing future exercises, and we are working with Cal OES to bring multiple training classes to our county this year. Next slide. For alert and warning, I first wanted to provide some clarification. This system is owned by the Sheriff's Office. Only the Sheriff or his designee can order evacuations and send alert and warning messages. This is a partnership between OES and the Sheriff's Office, and OES is in a supportive role only. For system administration, OES manages the alerting contract. OES manages the Homeland Security Grant Program, which we use to purchase the contract with our alerting provider. For database maintenance, OES assists with alerting signups and opt-outs. You can sign up today by visiting our website, mendoready.org. And also the alert and warning templates were created and are maintained by OES staff. OES staff test and maintain the operational status of the alert and warning system to ensure it's in working order. This is a requirement of IPAWS, which is the Integrated Public Alert and Warning System for WIA and EAS. We also provide technical support for dispatchers during events to ensure alerts go out quickly and efficiently. And at the sheriff's discretion, OES may assume the primary alerting role. We also complete any associated mapping that is displayed on our website, mendoready.org. And now I'll send it over to Jeff Adair to talk about the org chart on the next slide.
Thank you. If I may, through the chair, I'm Jeff Adair, Emergency Services Coordinator. During emergencies, I open and manage the Emergency Operations Center, or EOC. I also conduct operational area calls to provide our partners with information about events and receive from them impacts and unmet needs caused by these events. Prior to emergencies, we focus on preparedness. I prepare staff and the county for emergencies. Staff training for the EOC, exercises, plan creation and updates, public education, weather monitoring, and many other duties go into this preparation. This org chart you see on the screen is a scaled down version of what we typically see. The white section up top is the management section, and the section chiefs are represented down below that in the colored boxes. Each one of these sections typically has many people working under them. It's a scalable chart and scalable organization. By county ordinance, Darcy is the Director of Emergency Services. I see my job as training and preparing a team of experts to work under Darcy's direction during emergencies. Darcy is the ultimate decision maker. I would guide her through the meeting schedules and facilitate the activation and operation of the EOC. This is an example only, but as you see on the far left over there, the operations section, that could be staffed by IT if the event were a cyber attack, or it could be staffed by public health for a health emergency such as the pandemic. Next slide, please. This slide demonstrates the need for cultivating relationships and establishing a good rapport with our partners. It is helpful to have met and worked with people prior to an emergency. Internally, on the left side there, we deal with many of the departments in the county. Locally, we encourage community leaders to communicate their unmet needs to us. City managers, fire chiefs, police chiefs, municipal advisory committees, tribal leadership, nonprofit, and volunteer organization are some examples. At the state and regional level, Cal OES, Caltrans, and emergency managers from other counties are people that we collaborate with. Federally, FEMA, the U.S. Geological Survey, and National Weather Service are partners with whom we work. And speaking of National Weather Service, if Ryan Aylward is online yet, I will pass it to Ryan for National Weather Service presentation. Yes, thank you.
Okay, I'm going to share my, let's see, should I do this right? Sorry, my presentation disappeared. So there we go. Okay, can you see that presentation? Yes?
Yes.
Okay, excellent. Okay, so yeah, my name's Ryan Aylward. I'm the Warning Coordination Meteorologist here at the National Weather Service office in Eureka, California. And Mendocino County is one of the counties we serve, in addition to Lake County, Trinity County, Humboldt, and Del Norte. So I'm going to give you an outlook for the rest of the winter and then into the spring, as we look at what might be in store for the second half of the winter season, and then really looking at, how does that result in potential for the beginning of the fire season, essentially. So I'll jump right in here. Next slide here. So we currently across the region, we have a water year that starts October 1st, which is kind of your standard. So we get most of the rainfall through the year in our water year. And so the summer period is actually from the previous water year. And so since October 1st, we've had about, on the left-hand side here, about 110 to 150% of normal rainfall across the region. So anything in the green is above normal. Yellow is even much more than that. And some places in the dark blue there off to the far west are over 150% of normal rainfall so far this water year. So the start of the year has been excellent. It's been great to have this much rain through this point, and it hasn't been that cold. So we haven't had low snow or those sort of impacts. On the right hand side, you can see the total amount of rain off in the north, about 40 inches of rain so far. Places in the south closer to about 20 inches. But again, yeah, we're above normal in pretty much the entire county. Yeah, the entire county. So, what's that mean for water across the region? I don't have any insights besides what here is coming from the Army Corps of Engineers, with the lake now above the top of the conservation level. So that's good news, that the lake is doing well at this point in the water year. A drought across the West, it's been an excellent year. This is the first time, I believe, in 20 to 25 years that California has not had any drought anywhere in the state. So the last couple of years have been excellent for rainfall across the state of California as a whole, which is great news, because the southern part of the state has been having trouble the last few years, why we had the really bad fires in LA, for instance, but that's even been resolved. So La Nina is still favored. It's still in effect. I mean, right now we're still in La Nina. This is kind of to say it's favored. It's going on right now. So La Nina is just colder water temperatures in the tropical Pacific, and when that happens, certain weather patterns typically occur across the United States. Doesn't always work out that way, but this is often the way it ends up. So we get a wetter situation in the Pacific Northwest, drier conditions across the southern part of California, and we kind of end up in the middle. We also end up often with warmer conditions across the west, which has been panning out so far this year, with temperatures above normal throughout California through November and December. So not a surprise, but when you look at the continued outlook, January through the rest of January through March, continues to show the potential for above normal precipitation across the north. If you look on the left-hand side of this graphic, this is from the Climate Prediction Center. They issue these longer outlooks to give you an idea of what is favored to occur. Doesn't mean that is what will actually occur, but it's what is favored to occur. So they have above normal precipitation for the Pacific Northwest. So that means above their normal for that 3 months. It doesn't mean that places in Southern California aren't going to get any rain at all. It just means that it's favored for down there, for instance, to have less than normal precipitation. We're here right in the middle with equal chances, which means that it's just not sure. We're just not sure about how much rain we're going to get as we go through these next 3 months. And then the same pattern is in store for temperature below normal across the north, warmer across the south. This is a very typical La Nina setup where we have this. We're stuck right in the middle. And what we found is that from our research here at the Eureka Weather Office, for our region specifically, when you look at the season as a whole, La Ninas are often weighted towards the first half for rainfall. So we often get above normal precipitation across the region, October, November, December, maybe beginning to January, and then things start to die down and we get less rainfall in the second half. So we have built a big ridge over the west now. We're very dry, so it's kind of matching that, but it's not atypical to have a 2, 3, 4 week long period where we actually are fairly dry in the winter and then have precipitation come back. So don't expect it to be dry from here on out. I just want everyone to know that it is very typical for a La Nina setup to have the second half be drier than the first half. Looking as we go into April, May, June, there's that second half really starting to show that dry pattern from the Climate Prediction Center with below normal precipitation April, May, June period. So, and above normal temperatures across the West. So, what does that mean when it comes to the wet season and the fire season? The first thing to note is that we are not done with the winter, even though it may show that we're going to trend towards below normal as we get to the later half of the winter. We have had big snowstorms in February, March, even into April. It only takes one storm for that to happen and have a major event with low snow levels. So don't think that this doesn't mean that we're out of the woods. We will still see precipitation through the rest of the winter, and we still could have a low elevation snow event that could cause major problems. So, but things are trending towards warmer temperatures than normal, continued warmer temperatures than normal, and potential for things to get a little less active in the second half. So that's what this says. Seasonal outlooks just give us our best guess for what the winter could look like, but it's all about the individual storms. One storm, one big atmospheric river can cause major flooding. One cold system can cause a major winter event that then results in trees down across roads and people stuck. So you still have to be prepared for it. I do want to mention that there are other outlooks that the Climate Prediction Center provides, and if you're ever interested, you can just go to their website, just look up Climate Prediction Center. On the front here, the 6 to 10 day, 8 to 14 day outlooks, you can give an idea of what the next week to 2 weeks is going to be and what is favored to occur. So this was from just a couple days ago, and across the West, they had well above normal temperatures in the 6 to 10 day outlook and below normal precipitation across the West. We are 2 days later now. I looked at the newest one, and this below normal precipitation is a little bit smaller. But in general, it's looking like a continued dry period for the next 5 to 10 days. So feel free to check that out sometime. They also provide these outlooks for heavy precipitation. And just to give you an idea, this is the current one from a couple days ago. But this is the sort of thing back in December, they issued this. Let's see, this was issued December 11th. And they gave us a heads up that, the models and all the guidance was pointing towards a risk of high precipitation or heavy precipitation for the West Coast. Ended up going a little bit longer than the 21st, and they updated this a couple days later, but they even had a slight risk all the way through the 25th. So if you're ever looking you want to get some more outlooks into the future and get a better idea of what could occur, this is another thing that we look at and that you're welcome to look at on the Climate Prediction Center website. So one other thing I just wanted to quickly touch on is that we're actually going into the small hail season. Small hail is basically occurs what you're seeing in this picture. You get a shower that goes across a road, it coats the roads, and then you end up with a very slick roadway that can cause accidents really easily. So I want to emphasize small hail season is typically the second half. The second half of the season is when we get more of those cold lows that come down the coast and give us these small hail showers. So if you follow us on social media or just watching the news and you're hearing reports of small hail expected, make sure that you follow these instructions, because you really need to, you can't drive into small hail. Once you're into it, it's too late. You really have to be slowing down ahead of time, because once you're driving on ice, it's a problem, right? So we've been working with Caltrans CHP in the past to make sure that we share those sort of messages that people need to slow down. This is the sort of situation that typically occurs. We get these showers on the backside of a nice big old low pressure system in this yellow box, and then those move onto the coast. This is one that's out in the middle of the Pacific, but it was my best example I could share today. That's where we worry about small hail. It's not with the main rain band, it's the showers behind. And this is what it might look like as you're driving down the road, a shower off in the distance, it looks heavy, and then it ends up being all hail. So you really have to slow down as you're seeing those dark clouds ahead, rather than once you're in it. I also want to remind folks about the difference between a warning, advisory, and a watch. We have these different terms that we use at the Weather Service, and you really need to understand what those terms mean. If we ever issue a high wind watch or a winter storm watch, that means that we're thinking that something's going to happen in like 2 to 5 days, and the confidence is increasing that this could be a warning level event, something that's very impactful. Advisory is a little less so. It's not as impactful, while a warning is a very impactful event. So to give you an idea, just kind of put that together. Think of a watch as where you have all the ingredients are there, thinking like we're going to create something, either a taco or burrito or something. And now we're going to make the meal. And then an advisory is something that's a little smaller. So in this case, a taco, something smaller, right? But it's all put together now, and we're expecting a lighter event, something that's not too heavy. And then you have a much bigger meal, a burrito or something like that, where it's more impactful, it's a bigger thing, it's going to be a bigger meal that you're eating. It's not just a snack, right? So the warning is an event that's going to be potentially very impactful for your location. People need to respond to that and take protective actions to stay safe, essentially, at the warning level event. So for high wind warnings, for instance, we're expecting large trees to fall down, where an advisory, it's more like small branches and maybe a tree or two rather than numerous trees across the region. So just want to cover that. And the last thing is everything we have is we have criteria for everything. So for instance, for winter storm, this is just an example, snow below 1,500 feet, you only need 2 inches of snow on the ground, and we're going to issue a winter storm warning, because in those areas, it's really rare to get snow to those elevations. Above 1,500, we need more. We need like 5 inches of snow, because the environment can take it. Buildings are built to deal with that sort of snow. There are more snow plows around to deal with the snow. So you have more ability to respond to it, because you're just used to snow at those elevations a little bit more than at those lower elevation locations. We even have some special criteria for Trinity County, where there are more highways that go to higher elevations. So advisories, similar things. Anything below 1,500 feet, you're going to get a winter weather advisory. So if you see these headlines that are out there, understand that it's not necessarily the same for every location. We're trying to use the climatology and an understanding of what how people can respond to those events to provide the right sort of headline, so that you're not over responding to any given event. We work with emergency management to make sure that they understand all our terminology, and so that we're all working together to provide the correct message that goes out to everybody in the county. And these slides I can definitely share. Oh, and there's one other thing I just mentioned, that if you are seeing us start to provide probability forecasts, you'll see these on our social media. If you read our area forecast discussions, what we're just trying to give you is a probability of something occurring. In this case, it's 2 inches or more, or 3 inches or more of rainfall over a couple day period. It gives you an idea of the severity of an event, and whether we're really confident in that actually occurring, or maybe it's a low end event, but if it occurs, hey, there's still a 24% chance in this situation of Eureka getting 3 inches of rain. Doesn't mean that we're expecting it, but don't discount it as impossible. So those sort of graphics can give you those sort of information. So that's everything I have today. I know I went through things a little bit quickly. If there are any questions, I'm happy to answer them now.
I'm not seeing any questions from the.
Have a good day.
Goes.
Okay.
Are there? Oh, yes.
Go ahead.
And we have basically Schwinn disaster. Yes. room. Our own EOC for that. This are ready for notice. Sheriff was split. We worked our administration and the operations of it. The sheriff is response. He has the ability to be in the field, taking care of what needs to happen out there, and we work collaboratively at his direction as well. So thank you to the team. And with that, I'd like to read an email that we received just this morning. Good morning, Jeff and team. Larry and I will be watching your presentation this morning via Zoom. Wish we could be there in person. I'm sure you're going to be a fantastic piece. We're so proud of how the department has developed and grown. Go OES. Sincerely, Judith and Larry Castillo, Piercy Fire Protection District. I'd also say they're pretty proud of the 49ers as well. But
Thank you. Supervisor Hashtag.
Yeah, just a question about the earthquake yesterday southeast of Willits. So, like, what is the process that you go through when something like that happens?
I can speak to that. So we have a lot of resources. National Weather Service is one of those, but we have a lot of resources. So we get online right away and try to find out where the epicenter was, what the magnitude was, and then we try start the process of trying to find out if there were any impacts to our county. I noticed the chair yesterday asked, if there was a procedure for this, and I had been making social media posts the day before, and I made the contents, not the graphics, for 3 social media posts, one for preparation before an earthquake, one what to do during an earthquake, and what after an earthquake. And so just while I have everybody's attention, it's better not to go outdoors. If you're indoors in a sturdy building, you're better off staying there. Crawl only as far as you need to get to, it's drop, cover, and hold on. So you're going to go down to your knees. Crawl if you need to get to a more safe location so you're not underneath something heavy or something that might fall onto you. And cover your head and neck with your arms and hold on to a sturdy piece of furniture. So that goes for people in this chambers, but also people at home too. I did not. Travis lives close to the epicenter, so we talked about impacts from his house. I'll let him.
Yeah, if I may, through the chair. I happen to live about a quarter mile from where the earthquake happened, so there was no impacts that I was aware of. But normally, we would be in communication with, local fire chiefs, things like that, and they know that they need to reach out to us if they're hearing that there's damage, and we have not, at this point, heard anything.
if I may, through the chair, we reached out to all the departments within the county and asked if there was any damage at our facilities, and there was not. And planning and building also went over and did an inspection, which we normally do after the earthquake at the Ukiah Courthouse.
Thank you. I'm not seeing any other questions, so thank you all very much. Is there anybody in the room that would like to comment on this item? No? Madam Clerk?
Yes, we're seeing one online, Peter McNamee.
Thank you.
Thank you for the opportunity to hear this presentation today. It's really important. I am a volunteer with the Grassroots Institute's Mendocino County Vision Work Group, which has for the last 3 years been looking at how to plan for the future of Mendocino's coast. from Humboldt down to Sonoma. And one of the things that's become clearly evident is that we have a lot of trailer parks that are dotted along our coastline. Westport, Fort Bragg has multiple ones. Albion, Anchor Bay, I'm sure just off the top of my head, I'm overlooking several. And these are trailer parks that are at sea level. And what we also have become keenly aware is that as a result of the increasing severity of winter storms coupled with king tides, that many of these trailer parks are at risk of being flooded. And the concern that arises from that is that when you have a king tide event, when you can get tides as high as 8 feet, coupled with a storm surge adding on top of that another 6 feet or more of wave surge action, and these trailer parks are literally at sea level, and it's happening simultaneously from one end of Mendocino to the other. You have coupled with that flooding of Highway 1. So there's a nightmare scenario here. And I would hope that the county, in terms of not only its OES response, but also in terms of planning for future development and ongoing management of the coastal zone, would consider that you could have a situation, very dramatic situation, where homes and lives are endangered in multiple locations simultaneously at the same time when Highway 1 is disrupted by flooding and emergency personnel are unable to reach those trailer parks to help people get out in time, and lives would be lost. So I encourage the county to look at that very closely as it moves forward and become more engaged with the public and educating them about that. Thank you.
Thank you, sir. Thank you, gentlemen.
Seeing no further comment online.
Thank you. Next, we have a presentation from EMS and LEMSA, Jen Banks and Tammy Bartlome. Good morning and welcome.
Good morning, Board. Antle, thank you so much. My name is Tammy Bartlome. I am the Acting Program Administrator for Public Health Services, Emergency Preparedness Programs, and EMS. And with us today is Jen Banks also.
And good morning, Board, CEO Antle, County Council. My name is Jen Banks. I am your Emergency Medical Services Coordinator with Coastal Valley's EMS Agency. So we'll get started today. We brought forth for the board and for public education, we're just going to do a quick summary and review of EMS in Mendocino County and just sort of provide an EMS 101 of what our services look like around the county, in addition to LEMSA services and what the LEMSA is in comparison to the overall EMS system. We're also going to touch base just a little bit on some projections and concerns with the big, beautiful bill impacts on our frontline emergency services. Next slide, please. So just the regular EMS regulatory framework in the state of California. In California, we have 34 LEMSAs total, which coordinate emergency care for all 58 counties in the state, operating as either a single county LEMSA or a multi-county LEMSA. We work with LEMSA, who is the California State EMS Authority, to regulate, plan, implement, and evaluate local EMS systems. So the state authority is ultimately responsible for establishing the standards that we follow at the local level. So when it comes to protocols, the care we can provide at the local level, it's all governed and established through policy at the state level. At the local level, Actually, I'll hold that comment just to touch base on the big, beautiful bill connection. We do have some projected concerns, although we haven't really felt impacts of the big, beautiful bill just yet. We are concerned with some reimbursement possibilities that could impact local service providers. And next slide, please. Okay, so at the local level, the LEMSA responsibilities, these are just a few of the things that we do as your local EMS agency. First and foremost, at the local level, we are responsible for certifying all EMTs that work in the local system. We do all of the ambulance permitting for providers, and then we also accredit paramedics. So all of the paramedics that provide service in Mendocino County are accredited by Coastal Valley's EMS agency, and you have to be accredited by your local EMS agency when licensed with the state of California as a paramedic. We also work with all of our hospitals in the area. We do designation of specialty care. So this is in relations to trauma services, STEMI services, stroke services within our hospitals when patients arrive for ongoing care after utilizing the 911 system. We do all of the policy development and treatment guidelines that our EMTs and paramedics follow, and we do a heavy lift of quality improvement to ensure that our patients are receiving the best care possible when they use the 911 system. We also have a role at the state level. Most people know it as MOAC, and no, it's not the funny hairdo, but it is the Medical Health Operational Area Coordinator, where we serve all of our healthcare providers within the county to ensure that we can keep services going through disasters. The last thing that we want to do is actually close a facility during a disaster situation, but if we have to, we're definitely one of the primary contacts between the county and the state to ensure we can move patients and they can continue to receive all healthcare needs during a disaster-related event. Next slide, please. Okay, EMS in action. So we are a 24/7 service. We're available all day, every day to respond to emergency calls when they come in. And how it really works is the 911 call activates EMS, obviously. So we have our PSAP centers and dispatch center, and we'll talk about Howard Forest Dispatch in the next slide. Usually the first people to respond to a 911 call are our first responders, and those are all of our local fire departments. And in Mendocino County, we have a very large population of fire departments. I believe there's 22 total serving the entire county. So lots of fire departments that are often the first to respond to emergency calls. And those fire departments, many of them, as we know, are volunteer service providers where people respond to support their community in a time of need without pay. From there, we dispatch our ground ambulances. Depending on where you're located in Mendocino County, you will receive two types of ambulances. The first is basic life support. Basic life support units are staffed by EMTs, and then advanced life support are staffed by paramedics who can do a little bit more critical intervention and provide really essential care that you're going to receive if you were already in the emergency department in the back of an ambulance. Should your emergency be significant, we have a very robust air ambulance program. We're very fortunate to have 2 air ambulances staffed within our county. One is at the Ukiah Airport and the other is at the Willits Airport. These are two of the busiest air ambulances in the state of California, serving the very large geographical area of Northern California. But if and when a patient does need to be flown out, we're often, as long as weather supports it, we are usually very successful in moving patients for critical intervention utilizing our air ambulance system. And then, of course, our receiving and specialty care hospitals. So dispatch in Mendocino County. Howard Forest ECC is the contracted dispatch center for Mendocino County. Howard Forest, of course, many know is CAL FIRE. They are the designated fire and EMS consolidated dispatch center. So they receive all incoming medical and fire support calls and dispatch appropriate resources. Again, it's a 24/7 service. We're always available to respond when people need help. And then in addition, and a lot of people don't know this, because of the partnership with Coastal Valley's EMS agency and the LEMSA, we also utilize REDCOM, which is the primary dispatch center in Sonoma County. And REDCOM is our locally identified disaster support dispatch center. So through REDCOM, you have 24/7 access to your EMS duty officer from Coastal Valley's EMS agency. Should you have an emergency that needs to be dealt with right away. Our hospitals utilize EMS duty officer resources if they have something going on in the hospital that needs additional support. Our providers utilize the system as well. So it works really great, and it's a wonderful partnership with the County of Sonoma. Next slide. So most people know who our service providers are, but I just really wanted to extend my thanks and appreciation to all of our service providers, and I felt today was a wonderful day to recognize all of the hard work that they do within our system. One very important thing for the board, the county, and the public to understand that right now in Mendocino County, there is no contracted service provider to ensure that an emergency resource is available to respond when you access 911. I think this is one area where we can really bring Mendocino County up to modern times. I was listening to the board talk yesterday about modernizing our county and what things can we start with to bring us up to better standards. Most counties in the state have contracts for EMS services to ensure that resources are available to respond when the 911 call is made. Now, in saying that, I just want to totally enforce we have never missed a 911 call in Mendocino County. We have resources responding to every call, and we actually have very good response times considering how large our geographical response zones are in Mendocino County. So present day in Mendocino County, you do have 5 very supportive ALS providers. They are Adventist Health Mendocino Coast, serving, of course, the Fort Bragg and Mendocino coastal zones. You have MedStar Ambulance of Mendocino County. Now, MedStar has, existed in Mendocino County for decades, also known as Ukiah Ambulance in the past. Currently, they're serving the inland core of the Ukiah area, in addition to Willits, and offering a magnitude of support to Covelo when they don't have staff available for that resource. Laytonville Fire, of course, serving the Laytonville community. Coast Life Support District, serving our southern Gualala coast, and Ukiah Valley Fire Authority, currently serving the Ukiah vicinity as well, in addition to holding our interfacility contract service with Adventist Health. So they're really supporting interfacilities present day for the hospital. So outside of our ALS providers, we have our 3 ground transport providers. These are staffed by EMTs, and that's in Anderson Valley, Covelo, and Elk. Those fire departments support those services. As we mentioned, our air providers reach 18 and reach 35, serving from the Ukiah Airport. And then our base facilities. So we have contracts with all 3 hospitals in Mendocino County, and we are fairly fortunate that we all hospitals are one network in Mendocino County, so we work very closely with Adventist Health. But we have Adventist Health Howard Memorial, Ukiah Valley, and Mendocino Coast. And what that means is all hospitals are in good standing to receive our patients in their emergency department. They provide quality improvement oversight of all of the patients that are received by ambulance, and they do a lot of education and training with our paramedics as well. And then alternate receiving facilities. This is definitely evolving. For many, many years, we had special state permissions because Redwood Coast Medical Services is so far away from any other acute treatment or medical facility. We were given permission from the state of California to authorize Redwood Coast Medical Services as an alternate receiving facility. So Coast Life Support District out in Gualala, for special classification patients, they can transport directly to the clinic rather than driving the patient. It's approximately 2.5-hour transport for them to get patients to the appropriate hospitals. And then very recently, working with the community of Covelo and trying to enhance services for Covelo, we did also go through the same process with the state of California, and we were approved to authorize Round Valley Indian Health Clinic as an alternate destination facility. So this is a little different than our platform for Redwood Coast, as Covelo is staffed with only EMTs, and EMTs can't necessarily diagnose in the field, they can do assessments. So in partnership with the hospital, we've set up a call line where the EMTs can speak with the physicians at the clinic, and they can determine if low acuity patients are appropriate to transport to Round Valley. This is a wonderful enhancement for that community, as it allows those patients to be seen right there at their local community clinic rather than doing that very windy, slow drive from Covelo to Adventist Health Howard Hospital. And it really puts our ambulance back in service much faster than having them transport to the hospital when it works out. Next slide, please.
Okay, thank you. The revenue sources, as you know, are from service billings, one-time allocated PG&E disaster settlement funds, and those funds are used for providers to buy equipment, special equipment for their services, and then the county EMS enhanced funds. So some of the challenges that the OBB, Big Beautiful Bill, and it's just a challenge overall, is reimbursement gaps. So the federal and state payments do not cover the actual cost of services, creating a significant reimbursement gap, specifically with Mendocino County having high proportion of Medi-Cal residents. These cuts can further impact local provider reimbursement. Cost shifting. So according to the GEMS, which is the Journal of EMS, they noted in their June 2025 One Big Beautiful Bill and the EMS revenue collapse no one's ready for, that cost shifting has been well documented in health policy literature and poses a significant threat to the sustainability for both EMS systems and the broader healthcare markets. Studies have shown that when public reimbursement rates decline or the uninsured rates rise, providers increase charges to commercial insurers that make up the difference. So what does this mean for EMS? In the EMS context, this cost-shifting dynamic erodes public trust, distorts market signals, and undermines the ability of pre-hospital care systems to plan and invest based on predictable funding streams. As the rate gets lower, the less they'll be reimbursed, if at all, in some cases. Budget constraints. So budget constraints with the county's budget and everybody's budget deficits lately, it prevents long-term planning. It makes it really hard to go out multiple years in planning for our EMS system. So just last week, we spoke with Napa County LEMSA. Their county is their own LEMSA. We spoke to them about what that was like and what challenges they faced, because they are similar to Mendocino County. And they talked about, they have a system, what they call a quick life support or QRV model. And they look at the really hard to serve areas, and they stage 3 ambulances around the county in those hard to serve areas that are ready to respond. but it costs money. They contract with those services to do it, and it's a pretty hefty price. So when I first heard them mention that, I thought, where would we find the funding to provide that kind of service? So it really makes it difficult in our long-term planning, is when you're thinking about how do we cover this cost. Measure P funds, the only thing I'm going to say about this is the Measure P funds are distributed to the fire departments as stated in Resolution 22-159. Any new revenues from the proposed sales tax to the fund, sales tax is to fund fire protection and prevention. 90% is to be spent on direct aid to those agencies providing direct fire protection services, and 10% to fire prevention, resilience, and readiness.
Can I interrupt you for a question, please? Supervisor Williams?
That receive measure that departments are sterling percent medical.
One from 2020, actually, that was medical. 68.1. But the wording that I read you is exactly what's in the resolution.
Right. So that, I mean, that percentage, I would say a traffic collision probably has a medical component, a structure fire probably has a medical component. I think the number may actually be higher than what dispatch classifies them. But the point is, the county supporting Measure Fee and asking voters to fund it did contribute funds that are going to EMS services. Right. The 22 fire departments that are receiving Measure P, they're using it to benefit the public's EMS service.
If I could clarify, I think you're saying because fire responds to EMS, our understanding is those departments are not using the money for their ambulance services. They're only using it for the fire portion.
My point is, I think EMS is broader than just an ambulance, right? They're providing a response to medical aids. And so I just don't want to give the public the impression that the county and the taxpayers aren't contributing towards EMS. I think we are. It's obviously not enough, but I'm not sure if that statement is accurate.
So I did speak with one provider who has indicated that they do use the funds, Measure P funds, as both response for EMS and fire. But
Thank you.
As CEO Antle said, that's not true at all. All right, next slide, please. Sorry. Was there any other questions? I'm sorry.
No, thank you. Please continue.
Okay. I talked about this before at our very first healthcare summit. The eligibility changes could shift patients from insured to self-pay or uncompensated care, potentially by reducing ambulance providers' revenue by 15% or more. Where that number comes from is analysis and modeling that were done by healthcare consulting firms associated particularly with the American Ambulance Association and PWW advisory group. So I didn't make that number up. It's been analyzed as a 15% reduction. Increased operational strain. Without a primary care physician, individuals tend to utilize the 911 system as their primary healthcare entry point for non-urgent or chronic conditions. As of January 1st, 2026, new Medi-Cal applications for undocumented adults will be limited to emergency Medi-Cal only. This restricts EMS billing to only life-threatening emergency transports. Non-emergency or low acuity transport may no longer be reimbursed by Medi-Cal. So that will have a pretty sizable, could have a sizable impact. Next slide, please. Okay, the tax cap reduction we've spoken about before. I know you have heard about this before, with a 6% to 3.5 cut between 28 and 32. And what this affects reimbursement, the GMT, which stands for Ground Emergency Medical Transport Reimbursement. It restricts the revenue states can generate from the taxes to support medical programs. And then the Medi-Cal eligibility checks are going to be burdensome for billing for EMS providers. So a provider may see a shift in the payer mix as patients move from covered to self-pay, which historically has a lower collection rate. More frequent checks increase the risk of patients who may experience periods where they are temporarily uninsured. EMS agencies may face higher billing complexity as they must verify real-time eligibility more frequently to avoid denied claims. So there could be a gap when a person is reestablishing their Medicaid, Medi-Cal coverage. There could be a gap where they are not covered because they didn't do it and there was a holdup or whatever. And so EMS stands a risk of not being reimbursed. Next slide, please.
In the past, when we've presented to the board, we often hear we want to see numbers. We want to know really what our system looks like. So on this slide, I wish I could have had all vetted data and information for 2025, but being that it's so close to the new year, we just haven't received that data back from our dispatch center. They usually produce their end of year report by the end of January. So I'm happy to bring concrete and vetted 2025 numbers back if that is of interest to the board. However, in 2024, we're running about 17,000 calls annually in Mendocino County. That's a very, very significant call volume. And it definitely is, it's hard for us to meet every call with the structure of our current EMS system. But as I stated earlier, we are 100% arriving at every call in a very timely manner. Next slide.
Oh, sorry. That's our goal, is to try to create sustainability for EMS. One thing in our looking at various options for how to help support EMS or different fundings for EMS, one thing we learned in our research was that it's our understanding that there's a large portion of unincorporated areas within the county that do not pay property fire tax. There's a reason for this, but yet our providers respond in those areas. So is there a way to look at that and put those taxes on those properties that also receive provider care from our providers? So we're committed to figuring this out as a team and together. Next slide.
Some solutions and timelines. And this is where our presentation might turn and just get a little grim. So as of today, sitting here before the board, when we're looking at, short-term solutions to help stabilize and improve our EMS system, I come to you and very honestly say there are no immediate solutions to increase revenue and sustainability. We have kept this EMS system structure together with very dedicated service providers and billing and reimbursement programs that have supported them in their financial stability efforts. Should the IGT or PPGMT dollars be pulled back at the federal level, that will have significant impacts on reimbursement rates for our local service providers. As we all know, the payer mix in Mendocino County is not great. So reimbursements are a challenge. a medium-term solution that we could present to you. There are discussions circulating with some of our public service providers about the establishment of a JPA, which would sort of, coordinate services between a few of our rural public fire department providers. However, even with a JPA structure, it will help to support the departments and staffing efforts and reimbursement as a whole probably, but it's not an exclusive operation. So again, there's no contract under the JPA structure. So we still, the county, when I say we, would still be vulnerable because there isn't a contracted service provider representing this county, even with JPAs established. We can always pursue federal grants. Grants are great when you receive the grant funding and when you have staff allocated to manage the grants. At this point in time, there are no staff assigned to support any grant work within the county structure or at our agency, unfortunately. Develop local tax measures and proposals. I honestly come before the board today. I don't know how successful we will be with another tax measure really specific to EMS services. I think that, I live in Mendocino County and I'm paying a lot of taxes present day. And I do think that the public really feels that Measure P supports EMS as a whole. And Supervisor Williams, I respect your opinions. I would really appreciate an audit of Measure P to confirm usage and allocations so we can really see how many of those Measure P funds are supporting EMS services and how much is going directly to support fire services. We need fire to support EMS and fire needs EMS to support them. We work together very well. But when it comes to, financial support to ensure that these programs remain in Mendocino County, I would love to see more information on all of the departments and their financial stability and the support that they're receiving from the Measure P. Long-term solutions, of course, we can always advocate for federal and state policy changes, increasing Medicare and Medicaid reimbursement rates, but I'm not too confident that that's going to fly present day with all of the cuts that are starting to impact services that we provide. So it is a grim forecast for us, and we really wanted to come before you today just to provide this message and some education around it. Next slide. So the 2026 program goals, I would love to work with the county and the Board of Supervisors for an evaluation of performance contracts for exclusive operating area. We did do a lot of work in years past, and we ran an RFP for an EOA in Mendocino County. Unfortunately, the board at that time voted against the service provider that submitted the proposal, so that sort of fell flat and hasn't been revisited since. I think the most successful EOA for Mendocino County would be a combination of a 911 service provider and an interfacility transport provider, just because of the call volume and the current payer mix that exists within our county. Definitely consolidation, collaboration, and evaluation of a JPA for EMS services. As of now with PPG EMT dollars and IGT dollars, really having a public service provider being able to bill is a benefit because they do get the higher reimbursement rate. However, we have an outstanding partner in MedStar as a private service provider, so possibly a relationship with them as a subcontractor would ensure that all of our service providers remain in this county. We just structure the system a little bit different for financial benefit and gain. Reevaluation of our advanced EMT tier. We have been doing a lot of work just assessing if advanced EMTs would be beneficial for the more rural parts of our county. Unfortunately, in California, and this is definitely a much larger meeting discussion and presentation for another day, in the state of California, advanced EMTs, they can't do a lot in the standard scope. So our hands are a little tied with what bringing a whole new certification tier into this county would allow. Our agency explored this about 1.5 years ago with our medical advisory committee, and the consensus at that time was really to try to get the county to allow greater permissions for EMT scope within their treatment guidelines. And good news on that is at the State EMS Commission meeting in December in San Francisco, the commission worked with LEMSA and they are moving forward in the allowance of optional scope administration of Zofran, which is administered to treat severe nausea in patients. So we are definitely on track with the state. As soon as they give us the green light, we would like to implement optional scope Zofran administration for our EMTs. And our medical directors are also reaching out to the state to see if we could possibly add albuterol. It's just very timely. If we're doing one, if we could get the other in, it would be very beneficial for the outlying responders for treatment within this county. But again, we work under the discretion of the state of California, and that's not something that we, as your LEMSA, can just implement at the local level without state permissions. And then evaluation of alternate receiving authorization in Anderson Valley and Laytonville. We just completed this project in Covelo to allow the clinics to receive low acuity EMS patients. I think it really supports, we have such long transport times to our hospitals when critical care intervention is needed, but not all the time do patients have to go to an emergency department. Sometimes they just don't have transportation to get a prescription refilled. So if we could take those types of low acuity patients to our local clinics, that is a huge benefit for our service providers, the patients that we care for, and our system overall.
I'm sorry, go back. Sorry. Kind of tag teaming this one. And just to follow up with the advanced EMT, that is something, again, we will be reevaluating. The LEMSA has hired a new medical director. Already working, and our public health officer, Dr. Flaherty, he would like to meet with the medical director and have more conversations about that and what it could look like, or what are other alternatives, as Jen was talking about. Maybe we could get this working with the state to make some changes. I just wanted to add that. And then the LEMSA partnership. So as you know, public health began overseeing EMS October 1st, and one of the directives we had from CEO Darcy Antle was to look at LEMSAs to make sure that Mendocino County was being provided the most optimal service and at a cost efficiency. So we have met with multiple LEMSAs, talked to them about the services they provide, the cost efficiency, the challenges they face, things that work well, things that don't. We even requested a few of them to provide us proposals of what their services and costs would look like. And that included our current Coastal Valleys LEMSA. We asked them to do the same. We have received the proposal from the Coastal Valleys, and we will be coming to the board with an amendment. The Coastal Valleys has done an amendment to their contract for the 26-27 budget year, and there will be a reduction in over $100,000 to that contract. Going to be a substantial savings to our county, but also they're providing a good service, an excellent service to our county. Some agree, some don't agree, but it's a tough job. It's a tough job when you're the one telling the providers what they can or can't do. It's a tough job. So we will be bringing that amendment, as I said, to the board. We are still looking at, we will always research other LEMSAs to make sure, to see what they're doing, to see if we can implement that in our county and provide the best service to our residents. That's our number one priority. How do we all work together to provide the best services for our residents?
Yeah, if I could just note that, I just want to kind of stress for the board's knowledge, our current contract for Mendocino County, we are a partnership with the County of Sonoma. The current LEMSA contract is $448,000. So we really looked at services that we provided, and we tried to make really minimal costs, and we came back with a reduced cost at $311,000. We're still really going to provide the same services. We might pull we had to find one area where we could reduce the cost, and it was through our disaster work, but we are kind of ramping up Tammy and the preparedness department to be able to fill any gaps. But should, the county have a catastrophic disaster needs, we're definitely here to support the county going forward. And then we just wanted to, this is what we submit to the state of California in our EMS plan. This is just a clear visual of our ambulance service zones and fire districts. So if you ever have questions or are wondering who responds to what geographic boundary within Mendocino County, this map is provided just for clarity on who our responders all are. This includes both private and public responders. And that concludes our presentation, and I always appreciate questions.
Yes, thank you. Supervisor Williams.
As I've come to appreciate, the county doesn't. We've talked to the break terms public what these EMS receiving is if they go with hospital somewhere between $20 a year and $2,000 a year. I don't know what that number is. I'm sure it depends on the level of care, how efficient we do it, right? There's a lot of variables. But this county has never asked the public, is this a service you'd like to pay for? If we don't pay for it, we don't get it. It's like the roads discussion we have yesterday. If we want roads, we're going to pay for them. The base property tax doesn't even cover mandated services. Until the county does its mandated services, it's not going to be going beyond mandates. So trying to strong arm money away from the district attorney or sheriff to provide ambulance, not going to happen. Who takes the lead role in coming up with that number, what a reasonable level of service is, what it would cost, and getting ready to ask the public, do you support this? And the first step might be like what MCOG did, polling the public to see is there general support. And then if there is, put it before voters. And frankly, if people aren't willing to pay for it, that's the answer, that, we'll take a ride in the back of Bernie's truck to get to the hospital. Some people will say that that's the preferred. If it's $2,000 a year, I'll take a ride in the back of his truck. $20, yeah, I'd rather pay it and have an ambulance come and I have better odds. But I don't know what that number is, and I haven't seen any momentum to ask the public what they want.
Can you hear me?
Yes.
Okay. That is something that we are committed to work with the executive office to find some of those answers. As I said, we absorbed this program 3 months ago, so we're in the very beginning phases. One of the things we're looking at doing is meeting with our providers. First of all, map out what they feel best. Then look at different options that we might be able to come up with. Maybe we need to go to South Coast. I know there's many surveys that have been done. I would like to pull those together and look at them. So we are committed to doing that. I can't promise you that it'll be next week, but we are committed to looking at what we can do and what we can put together.
Do we think it's this year? And I don't mean to put it on you. I don't know who it may not be your job. And Coastal Valleys, I kind of see as the ambulance cops, right? Your regulators. Your job isn't to provide the ambulance. You could certainly help facilitate it and do surveys and steer us in the right direction. Who owns this task? Does anyone? Because I'm kind of pointing the finger. Somebody should do it. Is it a problem that nobody really owns or is responsible today for?
If I may, through the chair, we do have a team now that is willing to look at it, and they have my support to do so. So I think we can start gathering this information in the next few months and bring something back to the board. It May or June, but I think we need to do some work to really understand what that cost looks like to have a stable EMS, or at least get it more stable than it is currently, because it is the responsibility of the county to have this response. So we need to figure out how to shore it up a bit better than what we're able to fund currently.
Thank you.
Supervisor Klein?
Yeah, I want to thank you both for the presentation, and particularly the team at Public Health for being very prudent with our LEMSA contract. The $100,000 reduction is very important for us in these fiscal conditions, and so just appreciate the work that you've done with that, and thank you Coastal Valleys for working with us. I know becoming familiar with the LEMSA and the structure, I know we went through looking at what is happening across the state and what are our options, so I'm happy to see this in the short term and the work that will continue to be done on this.
Supervisor Haschak?
Yeah, looking at the funding, and we've had this discussion about Covelo and expanding the sphere that could be taxed for the services. It looks like on this map that you provided, you know, the white areas aren't under any zone or fire or ambulance service zone, right? And yet, if you're in that area, you expect to get services. You know, we're providing services throughout the county. So it just seems like every area of the county should be paying something towards ambulance service. And if that's a correct assumption, then how do we get to that point?
Thank you, Supervisor Haschak. I absolutely agree with you. I mean, I know, and I'm not an expert on all of the tax measures and what's available and what's not available. That's definitely not my area of expertise, but I don't disagree in that, you know, a lot of people live in this county that rely on a very important service when they need it, and they don't pay for it. And that creates, you know, hardship on all of our providers and the system as a whole. I do want to point out in the map, and I'm really glad you brought this up, those kind of white zones that aren't covered by a service provider. I do want the board to understand that the EMS enhancement funding that the county provides to, say, Laytonville and Covelo, that funding supports those that ambulance going out of their normal district to respond to 911 calls. So that is, you know, many, many years ago, it was like 2014 when we came in front of the board and asked for financial support to ensure that we had coverage to those gaps in our response areas. And that was the initial intent of the EMS enhancement dollars, to cover response, to ensure that our ambulance providers would respond to pockets outside of districts, if you will.
Yeah, so we have that enhancement, but, you know, the enhancement is on shaky ground. And so how do we, I guess who's going to look into how we can get everyone to pay?
If I may, through the chair, that's something we can work on. I'm struggling to find an email that I had received from Uma at LAFCO, and I know LAFCO is doing some work on this as well. So I think we can follow back up with LAFCO, see where they're at and what's all inclusive in that, what they're surveying for the fire districts. But I need to follow back up. But we can do that. And again, I think with the team, we could bring back something probably by April or May.
Okay, thank you.
Supervisor Mulhern?
Thank you. Back in November, we had a conversation about EMS, and I set out on a mission to speak to not only internal county staff, but partnering agencies, including LAFCO. So I think that what I discovered from that conversation is that there are a lot of currently moving pieces, including some shifting in the existing LEMSA, some opportunities that might exist elsewhere, as well as potential JPA, all of the things that we've discussed today. So I think that the most important thing as we move forward is that there is a high level of communication with the fire departments and the one private ambulance that we have in our community that serves as our sort of boots on the ground providers. And just in general, as a philosophy around all things that happened in Mendocino County, the state can be incredibly restrictive. And if Mendocino County can be more flexible to provide a service at less dollars for our community, I think that's where we need to be. The state has a lot of rules. We don't need to add our own, is the basic message that I take into anything from planning and building and just in general. But the state has a lot of rules, and if we can be more flexible, then I would love to see what that looks like, especially when we're talking about advanced EMTs. If there's opportunities for us to support a safe response, a quicker response, and a more affordable response to our residents, then that's what I like to see. And I think that the key piece for me, as we are talking about needing additional funding sources, is that we have the transparency and trust with the fire departments that are the ones that are providing the service. And even if an ambulance is coming, it is often likely that a volunteer fire person in a pickup truck may be first on scene to that traffic collision, which we know based on the statistics may be needing EMS support at some point. So I think I really appreciate the presentation. I'm glad that the community gets to hear it, but as we move forward, the transparency and working with the fire departments is a critical piece for me, as well as trying to be as flexible as possible while following the rules of the state.
Thank you for that, Supervisor Mulhern. That is exactly how we view it. It's not a one entity says something. How do we come together as a team, and especially with the providers that are providing this? So I agree with you 100%.
Supervisor Klein?
Yes, thank you. My comment was related to what CEO Ansel was mentioning. LAFCO is going through a series of surveys with the fire agencies, and definitely think there's an opportunity for information sharing as they go through that process. I believe LAFCO will be spending the next 2 years focusing on the fire agencies. I'm sure as Chair, Supervisor Mulhern has more information on that. But from my perspective as a commissioner on LAFCO, I'm also happy to be involved with that and help with some of the collaborations, and I'm sure Supervisor Mulhern is willing as well.
For that, Supervisor Klein, and yes, we'll probably take you up on that.
Supervisor Williams?
So I'm going to disagree. I think if we were to tax the areas that are white, it wouldn't solve the problem. There's not a lot of people living in the white. And you see fire districts forming where you have a population, you can generate a tax base, and you have volunteers who are willing to serve. And the white is basically the areas that are too rural for that to happen. Some of those white spots, the one between the on the ocean side between the pink and the green, I think that's a state park between Mendocino and Albion, and then the same thing that white between Albion, Anderson Valley, and Elk. That's probably Paul Demick Park. It's also a state park. We can't tax the state, and so you could fill in those areas, but it's not going to do any good for the tax base. Some of the white in the top northeast corner, I imagine there's population there, but it's not much. It's very sparse. And so it may be that the county could create some districts, but there could be more overhead in the county managing a district than the revenue that will be derived from a nominal annual parcel tax. So I don't want to give the impression if we just go after the people in the white, the problem will be solved. The people in the colored polygons, they're not currently contributing enough to provide reliable ambulance service in their communities. Those are the areas that have density where it should be more viable than the white. So I think the core problem is we haven't asked the public, what service do you want and what service are you willing to pay for? Because the state's not paying for it, the feds won't pay for it, the county can't pay for it. The county uses its property tax to pay for mandated services like sheriff, district attorney, jail, public defender, alternate defender, juvenile hall, etc. And some departments to support them by collecting taxes and setting tax bills. There's really, I don't see if in the next 5 to 10 years the county having excess revenue to support something that's not mandated. And so the way this happens is the public decides it's worth the annual cost. Maybe LAFCO can go after that, and the executive office working on it is great. I've watched for a number of years, 7 years up here, the county, actually going back to the Fitch study when it was at 2007, there's been all these attempts to study it, look at it, we're working on it, and nothing really has come to fruition. I think we're at the point of we just need to ask the public, come up with a fair estimate. Is it $40? Is it $400? And ask, here's what you would get. Is it something you want? And then work on that answer. If the answer is yes, we do it. If the answer is no, we leave this current system in place. But otherwise, we're just kind of, this conversation comes back time and time again, and we're staring at a screen like there's a creative solution that doesn't involve adding more funding.
Last question, Supervisor Klein?
Yeah, I just want to caution from making assumptions. I know my fire district recently had to do a boundary update in the last couple of years because there was a need for them to expand. And so while I understand your point, Supervisor Williams, it's not a silver bullet, for lack of a better term. It's best not to make the assumption. We need to do the groundwork to make sure that the districts are up to base. Going back to your point yesterday on fair taxation, we have to do that groundwork before we jump to the next step.
I believe that's it from the board. Any public comment in the room? Please.
Yeah, one comment is the chiefs are currently meeting right now and are going to approve a letter of support for the advanced EMT. So, probably present it to the Board of Supervisors for that. And the second comment I have is that whole white area, that stretch that you mentioned in there, well, our response area actually extends outside of that. And we often go outside those little pink boundaries that we have there. We've tried to, in the past, annex that portion, but we haven't been able to get a reasonable partnership with the county in terms of tax. So it hasn't worked at this point in time.
Thank you.
Through the chair, if I may, could I please get the speaker to clearly restate his name?
Clay Eubanks.
Thank you.
Dee Pallison from District 5. I live in the state responsibility area. I don't live in Laytonville. I don't live in Covelo. I don't pay anything for fire or EMS. But when I call 911, I expect them to show up, and they do. In the spirit of fair and equitable taxation, I should be paying for that service as well. And regardless if it doesn't fully solve the problem, that is the place that we start. I think you'd be surprised at the number of people who actually live in the white area. Granted, there are large areas of state and local parks and recreation areas, but there are a lot of people living out there who do not pay for anything, and I'm one of them. And that's not fair. We should be paying for it. The other thing I'd like to suggest, and you mentioned a JPA, but I wonder if we've looked at the cost effectiveness of maybe going to county fire. And I know that Supervisor Williams wouldn't support that, but it may be a solution to the problem. We have a very large fire department here in the county that already has a presence in every area of the county, and we may want to look at how CAL FIRE can help us solve this problem.
Thank you. Madam Clerk, anyone online?
Seeing no comments online.
All right, thank you. We're going to move on. So yes, you have something?
One quick comment, just based on Clay's expression. I just want to ensure that the board and the public and our service providers all understand. You have a LEMSA in place. We work with doctors. Doctors make decisions on the care that patients receive in the field. It's very much a safeguard to protect the board from making patient care decisions. So in hearing that, yes, we're going to submit letters to the Board of Supervisors, we know our service providers want us to explore and approve advanced EMT. There's a lot of roadblocks, as I previously stated, in California, where advanced EMT, it just might not be the best platform. There are only 2 or 3 LEMSAs in the entire state of California with the advanced EMT certification. It's not a common certification. It's a big lift for a county that doesn't have a lot of funds to support ongoing training and oversight at this point in time. We just reduced our contract and the services that we are providing. Creating an entire new certification tier comes with a very significant cost. So I just really want to appreciate that we do have doctors, and the doctors make the decisions about the care that our EMTs and our paramedics provide to those that utilize our services in our communities.
Thank you. Thank you both very much.
Thank you for having us here today. We appreciate being able to share this information with you, and just rest assured we're going to do the best we absolutely can. Whether it's advanced EMTs and finding some funding, we're committed to it.
Thank you. We're going to move into the nonprofits, and the first one up is Jackie Williams from Ford Street. Miss Williams, you're welcome to come up and sit in one of these other chairs, or if you're more comfortable, you're more welcome to stay at the podium.
I've been sitting too long. Good morning, CEO Antle, County Council, and members of the board. Thank you for inviting me here today. My name is Jackie Williams, and I'm the Executive Director of Ford Street Project. We can start our slides. Next slide. So our mission has remained the same since the inception of Ford Street, which started as a program under NCO in 1974. And that is to help Mendocino County folks that are addicted and unhoused attain sobriety and improve their self-sufficiency. In 1980, Ford Street became a standalone 501c3 nonprofit corporation. Today, we're organized into 3 different business units, and I'm going to go through each business unit with you in a moment. Our combined staff is 44 intrepid employees, and I say that seriously. There isn't a business unit that we have that doesn't serve people that are experiencing or have experienced significant hardship and trauma. And so when you work with the population of folks that are trying to attain sobriety without food, without housing, it's a tough emotional job as well as just the day-to-day work activity. Next slide. Our largest program is the Ukiah Recovery Center, and that is where we deliver our substance use disorder services. It's a residential treatment program, and it's located in Ukiah. We're lucky. We're not that far from the hospital, who we rely on regularly should there be a medical emergency. It's really nice to have them so close by. Yesterday, Supervisor Williams, you mentioned you toured I think you said a women's recovery center in Portland. I'm going to insist you come to ours. You've been invited 4 times in 5 years. It's time you see what's happening in your backyard. This is a new building that's been added that has expanded our ability to serve more people. This is funded by BCHIP, or Behavioral Health Funding, from the state. Immediately behind it is the 24-bed additional sober living environment that was funded with funds contributed by Northern Circle Indian Housing Authority. So at the Recovery Center now, we've gone from being able to serve 30 folks to 60 folks. 12 of those residential treatment beds are for withdrawal management. Our agency is the only place that is licensed to provide that withdrawal management other than the jail. So there's a real need for folks that are intoxicated for withdrawal management. If they can pass the medical screen that usually happens at the ER, we can bring them into services. Most of the time, those services are 5 days. And then the client leaves, or we start talking to them about interest in further treatment. So when you look at our number of people we served last year, it's 280 people. But what that might be is a person that came for withdrawal management 3 times, and then when they finally joined the residential treatment program, they were there for 30, 60, or 90 days. So our numbers of people served is kind of difficult to ascertain when you throw those 5-day stays in there with the extended stays. I want to also thank Partnership Health Plan. Years ago, we were dreaming of being able to provide these services, but couldn't figure out how to fund it. And so now, if you look at the folks we've served, it's like 97% are drug Medi-Cal. So these are people that would have had no ability to pay. Rarely do people have insurance for this, and especially in the past. It's a little more common now. And so, again, this is a program within Mendocino County serving the whole county and surrounding counties that can really help people begin to restore themselves, whether it's not just their health, but their sobriety. We're still averaging 50% of the time people come in unhoused and unemployed. So that's why the sober living. If we help you attain sobriety, but you still have nowhere to live and no way to support yourself, you know, we're halfway home. I think the concern, and this concern happens with every one of our programs, is what will happen with that funding? Because that's in jeopardy along with other funding sources. Next slide. We call these 2 programs our community benefit programs. And the first one is the Unity Village Family Shelter. So this is an emergency shelter for families, usually small family units, because again, this is like a boarding house. So we don't have, you know, big apartments available for the shelter. And I have to say that this has been the most challenging of all programs to fund. And right now, with what we've learned from some of the information we've received from HUD, is shelter funding is being reprioritized, or, you know, not perceived as valuable as other types of housing. So we're concerned about providing this service, how we will provide this service in the future. Right now, we have a contract through the Continuum of Care that is in place and that will carry us till June. So we have just a couple months to figure out how we fund the shelter going forward. Yesterday there was some information that I was listening, and I heard one of the financial discussions about that there are times that funds that we get from the state can't be rolled over, or they have to be reallocated. I wanted to share this with you about our shelter to give you a real live example of what can happen to a small nonprofit when a county miscommunication happens. The contract year before this year, we lost $200,000 that we expected we'd get because of a carryover. And it took them 6 or 8 months to tell us that, you know, when we started not getting paid and trying to follow up, it took us months to figure out what happened. For a small organization like 4th Street with you know, combined across all of our programs, a $3 million annual budget, losing $200,000 was more than a hardship. So there's real reasons to create more sense of urgency about figuring out the funding, because for those of us that rely on it to provide services that I hope you see really do support your community, it's important. Next slide. This is the food bank on 888 North State Street. We were given money from a couple people who left bequests in their will, and we were able to really get the food bank up to the standards that you'd want your food bank to be. So we had to add the fire sprinklers and just genuinely think about how to use that space in a more safe way, and got that done just in a nick of time, because we're probably serving, well, at times it feels like twice as many people, but I think it's depending on the day of the week, but we're serving significantly more people. I know you heard during the Thanksgiving time, there was the fear in November that people with CalFresh benefits, they were going to be held back for a while or whatever. With working with the Amendo Food Hub and the other food banks in our community, we all got together to figure out what could we do if people literally who rely on those benefits, if they're withheld, because food banks can't cover that gap, but what could we do? And I have to say, every food bank and pantry in the county saw a significant increase in people reaching out, and ours hasn't really fallen off. So it's easy for people to understand, because anybody that goes shopping in the grocery store has seen how the costs have gone up. So some of the people we support at the food bank are employed. They just are having a difficult time paying rent and food and caring for their families. So I think 4th Street's had a strong commitment to the food bank, believing that it's just the right community effort that we should provide, because so many people in need benefit from this, but the costs have really grown. So for the first time in years, I had to ask that we double our goal in our annual budget. The county provides $850 a month, and every other dollar we raise through a donation. This year, I was a little worried about saying, thanks for helping us raise $100,000 last year, now we need $2, but we did it. We did it. I think people understand and are aware of the food need. It seems to be a common situation. So again, I'm extremely happy with the response we got during the holiday Ukiah Daily Journal Food Bank Drive that's been going on for 39 years. So it's not like the community is not supportive of food banks, but I don't think any of us are really prepared for what it would really be like if those CalFresh benefits were substantially reduced. And so I think there are things on our radar that we have to watch and pay attention to, because I don't think your network of food banks will be able to cover huge gaps if some of that falls away. When the federal government cut the federal food benefits, it cut the grants that are the large food bank we work with. The Redwood Empire Food Bank got for transportation. So before that happened, the trucks that came here, that was a grant paid, the transportation part was a grant paid for by the federal government. For us to maintain the level of food that we need for the folks we're currently serving, I'll have to buy $1,000 of food a month and pay Redwood Empire $2,000 a month for the additional transportation. So the the cost to operate food banks and pantries is going up, and I don't know that we'll see those costs get reversed in the near future. So it's just something that's being felt throughout California. So when I said, you know, we need to double the money we need to operate the food bank operates with 2.5 people and, you know, a lot of volunteers. And so this isn't a place where, gosh, the, you know, salaries and lots of those kinds of costs drive the boat. It now, you know, that additional $36,000 will just be needed just to keep us to what we were providing a year ago. So do you have questions for me?
I have one. Yesterday, when we had public safety up here, there was a lot of conversation about the, mainly around the addicts on the street that were motivation. On that at all? Be
I think what happens is the people finally get really ill and they end up in the ER. And I don't, that's a rough spark of inspiration, but usually it's an ER doc talking to them about, and usually they've been in and out of the ER multiple times. And then they tell them, you know, you could go through a 5-day detox, take these meds that will help you with your symptoms, and people could, you know, work with you to talk to you about what's next. And so that's the typical path in. But again, if somebody is able to get their minimal needs met on the street until they have, you know, have an accident or have a health emergency, we don't see them. The other place we have referrals is from jail. And so that's another, I guess, moment of inspiration is, would you work on your addiction rather than stay in jail? And so, you know, I feel like we do give the folks that are living rough quite a bit of latitude and have to, because they're adults with rights. But I would think the most common entry into the recovery center is when they finally get scared because of the health problems that they're experiencing. And you know, that's a rough way to do it, but that seems to be one of the most common.
Thank you. Supervisor Mulhern.
Thank you. I just wanted to highlight for the board, because I know that not everybody knows just the lengths of challenges that the 4th Street project has had, not only with county funding, state funding, federal funding, and I think it's an organization that continues to show up in our community and adapt to the needs of our community, especially when called to do so. So I wanted to just highlight the ability and just the really wonderful work that your team members do every day with connecting folks to jobs and housing. And I attend the majority of the drug court graduations, and it's very often that those folks that are successful have gone through the Ukiah Recovery Center or some portion of a system that Ukiah Recovery Center offers to people, not just residential stays, but AA and NA meetings and outpatient treatment. I think there's a lot of emphasis in our community placed on residential treatment as the one thing that somebody might need, but I just want to highlight that there are other opportunities for people to get sober and have a productive life with a home that doesn't always involve residential treatment.
Right.
And so thank you and your team for really considering that and adapting to those needs as is important to try to meet the most people that we can meet where they're at.
I think that we serve probably the largest need. And I think that what I'd like to leave you with is most of the folks before they became addicted were self-sufficient. And so our goal is to get them back there. So we don't take people that are severely disabled or people that have a very serious behavioral health issue. We're not, our license is not for that. We have a medical director. We do not have a psychiatrist. So we are really targeting our programs for the folks that will need to get back to work. There are a few retirees that also we can help get them back reconnected with their Social Security, but most folks are folks that need to get back to work. And you have employers in almost in our neighborhood in Ukiah that are very willing to hire these folks. And I think they're cautious, and they do it in a, our folks present, I really need a job and I need a full-time job and all this stuff. And they usually start them out part-time to really see if they're going to meet their commitment and hold them to account. Because part of that, the lesson that they're learning is how to be accountable in the world and be responsible. So I feel like we have some Sonoma Sweepers, Slam Dunk Pizza, Hobby Lobby. I mean, we have some folks that understand that, have had success with working with new employees in recovery, and it's a real benefit to our folks. Once they get that sense of, I have a safe place to live, I have a job, I can save money, we work with them and set those savings goals. So they are doing everything they possibly can in this really difficult, challenging economic time to get themselves prepared for next steps. So thank you for that. Also, some of the people that can't do residential treatment are people with small children, but there are other programs, that we can refer people to. And I'm also proud that I guess we'll call them the graduates of our program, have created their own alumni association. So I feel like the recovery community in Mendocino County is active and robust and really tries to support one another and support the referral process where, it's often difficult for a family member to advocate for somebody to go into treatment because those relationships have been really tattered. But having another person come alongside you that's been where you are usually is more effective. And I think we're lucky that those people are so active.
Supervisor Klein?
My question was answered, but I'll just say briefly, thank you very much to the Ford Street team for all the work that you do.
Supervisor, we have one more. Supervisor Haschak?
Yeah, just a few months ago, you had the opening of the expanded dormitory for the recovery center. And really, I know that a few years ago, you wanted funding from Measure B, and we weren't able to give it to you at that time. So I really appreciate the way that you went and looked for other funding sources and made it work.
Thank you, John. And I think the truth is that I had a partner in Northern Circle that needed that housing as much as we did. I mean, I think the people that endeavor to help folks gain their sobriety understand what's needed. And I didn't ask. They came to me. That's amazing. So before I say goodbye, the person that's responsible for the food bank and all the housing programs, so that includes the housing program at the Ukiah Recovery, is Drew, like a meanie hair, wave. And Ryan, next to her, is the SUD director at the Recovery Center. So those are the brains behind the madness. Thank you.
Thank you. We are currently running about 15 to 20 minutes behind. We have a scheduled break at 11:05, but we do have one more presenter. Is it the will of the board to take that 10-minute break now and come back? Yes? Okay. Yeah, all right, we'll be back at 11:10. Back. Our next nonprofit. Kelly?
Hi, good morning. I will start us off, well, you can go to the second slide, or the third slide, actually, we'll jump. Good morning, Victoria Kelly with Redwood Community Services. Before I jump into talking a little bit more specifically about our programs and some of our crisis respites and housing programs, I want to take a bit of a back step and discuss, take a step back and share the bigger picture of RCS and a little bit more of the highlights that some may not know. So RCS was founded over 30 years ago. We've been serving Lake and Mendocino counties since our inception. And we're deeply committed in serving our community through services and supports focused on community gaps and needs. RCS is rooted in our community's wellness, and in our organizational structure, we centralize the humans that we serve and the individuals who make up our RCS team. Throughout our history, so I've highlighted kind of 4 different sections that I can encapsulate our history into. But throughout our history, I think the one thing remains present, our unrelenting hope and healing. When I look at the timeline, which I get to do once a month, I do a onboarding session with new employees and go through our history and our values and what has led us to where we are today. I'm reminded of the continuous persistence and perseverance RCS has had. RCS has been at times criticized for growth or change, to which I will remind us all that without growth and change, things become stagnant, things die. As a principle at RCS, we believe change allows us to provide organizational stability, and it's necessary for diversification and ongoing sustainability. Throughout this timeline, change has been precipitated by people who have showed up at our doors suffering and in pain and with unmet needs. Time and time again, we have built a service or a program directly because of a child, a youth, or an adult who didn't fit into a box of our community's existing network, and we innovated and developed programs to meet those needs. RCS also has many times been on the forefront of important out-of-the-box thinking, continuing to center the people we serve in our decision-making. We carry forward the hope and belief in people's ability to change, grow, and ultimately heal. We also value and take seriously our responsibility as a community-based organization in partnership with our county and our cities to address concerns and shared priorities. I know you guys talked a lot yesterday about priorities and have been for some time. We do not sit back and wait, but we lean in and take on the responsibility to be present, accountable, and engaged in our community's needs. We do this on a local, regional, and even at state levels and ensure that our rural representation is heard. I wanted to highlight this because this is the foundation in which we center our organization's services, our community engagement, and our structure internally. Next slide. The next slide is not really a slide. It's a handout, so I handed it out to you all. And there are some in the back, but this is the representation of our departments and programs. Many times I think RCS gets pigeonholed into some of our largest programs, but we do serve 3 primary counties. We have over 300 employees. We also have anywhere between 3 and 5 additional specialty mental health contracts with other northern counties, and we're also a partnership contractor, which therefore we serve the 24 partnership counties. So this is our array of programs throughout those 3 counties. I'm happy to discuss any in detail at a later date, but today I'm going to highlight some of our most, I think, impactful as we go through. So next slide. First, our housing and homelessness and shelter programs. So we have Building Bridges Emergency Shelter that is here in Ukiah. Our shelter is a 55-bed facility for women and men. And we have a very strong collaboration with the jail and hospitals in terms of discharge and supporting their supporting individuals and stabilize housing for individuals discharging or with follow-up needs. I want to highlight, and here I have the 5 keys for effective emergency shelter that came out of the National Alliance to End Homelessness. We have a number of standards that we meet and we follow through the National Alliance to End Homelessness, the U.S. Inter-Council on Homelessness, and the Interagency Council on Homelessness. So these standards really oversee and provide us guidance for our low barrier housing first practices. So there's a lot of, I think, bad publicity around housing first. And I think one of the aspects I want to really highlight and push for RCS perspective on housing first is not housing only. When we get someone into housing, we do not abandon them. There's wraparound services that have supported them to get into the housing, and then we'll support them throughout their permanent housing. And so we do find housing, support their move-in, and then stabilize for long-term success. We also have our day center where there are support groups. We engage in a neighborhood cleanup routinely. We have showers, laundry, and of course the housing search and support. And then we also have a Hamilton Haven emergency shelter, which is in Lake County. And because our 2 counties have a unique, I think, interwoven interconnectivity, Hamilton Haven does support Mendocino residents, and Building Bridges also serves Lake County residents. So we are the operator of that 35-bed shelter in Lake County as well. Looking forward, we have applied for a B-TRIP funding to expand services on our B2 campus to develop adequate facility for outpatient substance use disorder services, mental health services on site, and then expand our physical health services that would be available. Additionally, we wrote into our B-TRIP grant 6 sobering center beds, withdrawal management beds, that I know really would meet a need on that campus and with those individuals. Next slide. So the Housing and Homeless Services is now a part of our integrated health programming. Part of CalAIM expansion was the additional benefits of enhanced care management and community supports. And that is what encompasses our integrated health services. Enhanced care management supports individuals in breaking down barriers to meeting their whatever needs are going unmet, and that contribute to their mental health challenges or homelessness or physical health challenges. And community supports, there's 12 of them that are authorized, and many of them are in relation to housing deposit support and housing navigation, rental assistance, which we provide. One of the things I want to highlight, given Medicaid changes that we are all monitoring, ECM and community supports are not part of the California waivers under Medicaid. And so they are authorized under a managed care authority and have some level of protections moving forward, although obviously things can change. In the face of the changes that either could come and or that we know of and or could come later, RCS has really understood that one of the changes we need to prepare for is to shift and rethink our role in terms of Medi-Cal eligibility and reassessments. Our clients are on Medi-Cal and need to maintain Medi-Cal for a slew of resources, not just the resources we provide. And so we did, through Partnership Health Plan, they just released a grant, and we responded, and it's specifically around eligibility, and I think they're really forward-thinking in this way, and we responded to the grant to ensure that we would have in-house eligibility experts, eligibility practices to ensure the clients that we're serving across the spectrum, but specifically in our integrated health services, maintain eligibility and do not drop, which would ensure that access and payment would continue as well. So just a little Bit of data, our ECM year-to-date services, our ECM clients that we've served year-to-date is 269. We've served 118 of those folks in housing navigation, and then 41 of those folks have moved into permanent housing since July. Our housing stabilization, which is households supported in housing, we've served 74 individuals. And between building bridges and integrated health, we have an unduplicated serve of 881 through our ECM integrated health, community supports, and building bridges housing support. Next slide. So here is our crisis continuum, crisis services continuum. It's not linear, so it doesn't go in a linear continuum fashion. People can access at different points through this continuum, but we at RCS operate the county's warm line. We do operate our own crisis response line, and then we triage for mobile crisis. Mobile crisis support by the county is provided during the daytime hours, and then RCS is the after hours overnight support. We also are backup support for the county mobile response team in case they are out on calls, such as CORE or their MOPS. So if a mobile crisis call does come in and they are otherwise tied up, we do respond during the day if necessary, but we are the overnight mobile crisis responder. We also have the crisis intervention and response that we're continuing to provide at the 3 ERs. We have crisis walk-in centers in both Ukiah and in Fort Bragg. We have crisis respites, which is a unique model. This is a partnership with our counties, Measure B, and Adventist Health. We have two. We have Cypress in Fort Bragg, which is a 4-bed facility, in Madrone here in Redwood Valley in the inland. And these programs are short-term in nature, modeled for and have very wide eligibility because of our unique partnerships, but are modeled to support people in a short-term nature, trying to stabilize them outside of the ER. So they may be able to be on a safety plan, but don't have a great space to maintain their safety, and can come into crisis in Madrone for a short period of time and stabilize, and then we care manage and care coordinate them into a more permanent situation. So that may be moving with family, maybe moving back independently, and it may also look at stepping up to a facility. So one of those step-ups may be into our crisis residential, which was a Measure B and B-CHIP, a Measure B funded program and support, and we're the operator currently. It is an 8-bed facility here in Inland. I spoke a little bit about mobile response. I know also Janine yesterday did discuss that there may be some changes to the mobile response mandate, and I think there is some data that the state is looking at, I think also in rural communities, about the challenges for mobile response. And that's why you'll still see our crisis intervention response at EDs. We haven't been able to really see the uptick of mobile response the way that I think we all had hoped. We see it occurring, it is just not overtaking the ED response that we had hoped. In our crisis supports, we also have a very robust aftercare services. So we provide 60 days of aftercare resources for all individuals. So this is not just for Medi-Cal beneficiaries, but it's all individuals. And part of those services and our services kind of outside of any of the mobile response, crisis intervention, the residential services, is a coordination of care. So we have a strong coordination of care with other providers in the community, whether or not that be other specialty mental health providers like Tapestry and or our med management provider with Anchor Health. So we ensure that people are connected back to to the services they had previously been engaged with, and or support them in engaging to services for stabilization. So just a little bit of data real quick. Mobile crisis calls that we've had this fiscal year is about 69. And our crisis interventions that we've provided is 1,012 for this fiscal year, which is an average of 160 a month. So those are crisis intervention assessments where we are either assessing for an acute placement and or safetying back to community. And our crisis calls, our warm line calls, are almost 5,000 for the fiscal year with an average of 781 a month. So our call line, or our crisis line, is pretty busy. Next slide, please. So a part of, we have our crisis services, which are robust and busy in nature, but we also have a very robust outpatient specialty mental health program, and we do provide these in all the counties that we serve. And I just wrote down here the list of modalities of services that a person may come in and access. So that's their assessment and treatment planning, therapy, individual rehab, group rehab, individual care coordination, intensive home-based services, therapeutic behavioral services. And that's a general modality of services an individual may be eligible for. And in the box below, you kind of see the, well, in these modalities, I think some of the keys to our services, our outpatient, is we individualize needs, we individualize care. Our services, by and large, are in-home and community-based. So many of our services do not happen in office settings, do not happen in a typical clinic. They are community-based, meeting people where they're at. We focus on breaking down barriers to additional access or access to our services as well, with meeting transportation needs or community-focused services. We have the interdisciplinary support and coordination, and we have a structured management with no wrong door. So, we do have adult services and children's services, but there is a no wrong door to access any of these. I want to highlight, we have a couple, I think, unique programs within our outpatient. The Interpersonal Skills Training Center, which we call the Ranch. It's a group rehab program for outdoor education, and we have been doing it with children for many years, probably almost now 20 years. But we have just in 2025 moved into providing an adult programming there, and it's been really exciting to see. Assertive community treatment is something that actually, I'm going to talk a little bit about BH Connect in a second, but is outlined in BH Connect as an evidence-based practice. We in Mendocino County have been doing this as a community and community providers for some time. So we have an ACT, a very active ACT group. So all providers meet every morning for 30 minutes to discuss the ACT clients, discuss who's going to be seeing the client today. It's a shorter list, but coordinating care and ensuring that we're meeting the complex needs of those individuals. And then we also participate in behavioral health court, both inland and on the coast. So BH Connect is something to look forward to moving forward. It's another initiative aimed to transform behavioral health services at the state level. They like to do transformation projects. This is just another one. But we are excited about looking forward to expanding our ACT services and expanding the peer support specialist integration. We have a number of certified peer supports on staff. And we are excited about that additional integration, and then the opportunity to implement additional evidence-based practices throughout our programs. Just real quick data on our specialty mental health service total. I do have at the end our client total, but Year to date, currently, we have provided 19,432 total services across all clients, which is an average of about a little over 3,000 a month. Next slide. I lastly want to focus on our residential programs because these are, I think, the programs that are serving the most complex, the most challenging individuals in our community, and that we have built out of community need, and we've built through innovation with our county partners. So we have an enhanced short-term residential therapeutic program, which is an STRTP for, it's for youth, children and youth. We have 2 of them actually, one in Mendocino County and one in Humboldt County. And this is an innovative model of care, which is a state project. We were actually one of the first providers to receive an innovative model of care program and rate approval, and was built for one individual initially, one young woman that we built it for, and then continued. We have our adult residential programs, Haven House and Harmony House, and those are for AOT individuals and conserved individuals who are hoping to move off conservatorship and be back living in the community. And those 2 programs, I think, are a very unique model that has been in existence because of the collaboration and partnership with our behavioral health and recovery services. We also have TAY housing, our TAY housing with Gibson House for transitional housing placement program, so former foster youth, and youth who are transition age and are struggling with their mental health and need more 24-hour care. We have our crisis respites, like I said, we have Cypress and Madrone, crisis residential with Phoenix House. And then I did want to highlight, we have our peri and non-peri residential substance use disorder treatment in Lake County. We do serve, this partnership contract, and we also have a Mendocino contract. Thule House is a really special program where mothers do seek out residential substance use treatment, but also bring their children with them. And so we have childcare, and we have parenting support and enhanced, enriched activities for mothers and their children during the beginning of their recovery. So those are our spectrum of residential complex, serving the most complex needs in our community. Next slide. Just a quick data and outcomes. There's so much data and so many outcomes we could provide, but this is just a snapshot. So these are our crisis year-to-date totals for adults and children, unduplicated clients that we've served on the crisis side and on our outpatient side. And then I did list, these are 3 of the outcome measures that our clinical teams utilize. So the PSC, the PHQ-9, and the GAD-5. And the percentage of improvement well, it was last year, 2025. And lastly, last slide, next slide, sorry. I just wanted to highlight, because I know there's been a lot of conversations around priorities and strategic planning, and as a community, where are we going and how are we getting there? And RCS is governed by a strategic plan as well, and we have these strategic goals that are set out, and we engage and align these goals with our community needs and community partners. We have tangible goals that we reach out internally, but we also, know that it has external impacts within our communities. So our fiscal strength, our quality of care, being the employer of choice, having strong communications, and building in our equity and diversity and inclusion throughout our programming. So I just wanted to highlight that for you all. The last thing I do want to say, and I'm going to just steal Bernie's question to Jackie, is this idea of spark of motivation, because I heard that yesterday. And although I believe that, individuals who have a spark of motivation do probably progress faster and easier, At RCS, those are not the individuals we tend to serve. We are serving folks that don't necessarily want services and treatment and are pushed away, denied, exited from other services. And we believe that getting basic needs to those individuals, bringing essential services and essential needs to them can be the beginning of their healing journey. And we don't discard or give up on people for the needs that they are presenting with. So our services are built to treat people, and we do not discharge or not serve people for the symptoms that they are in treatment for. And so we just don't give up. And so this idea of motivation is wonderful. And I think, yes, we have many individuals who are motivated for change. And we have many individuals who can't get there just yet. And we want to help them as well. So that's my presentation.
Thank you. Supervisor Klein?
Yeah, thank you for the presentation. Everyone has service provider serve different populations. On provide tremendous County.
Any other questions? Thank you.
Thank you.
Like to comment? Madam Clerk?
Online.
Thank you. Next up, we have Northern Circle Indian Housing Authority. Mariah McGill. Whenever you're ready.
Individual departments and showcases the work that we do. Now this is for last year. We're currently developing our annual report for the most recent fiscal year, so stay tuned for an updated version. But thank you again. It is an honor to be here today. This is the first time that we've been invited to have this conversation and to meet with you all, and I hope it's not an introduction, and I hope you're familiar with Northern Circle. But if you're not already, we're happy to provide lots of information. Next slide. I'm Mariah McGill. I work as the Deputy Director at Northern Circle Indian Housing Authority. I just entered my 12th year, and I'm a local in Willits and lived in Mendocino County my whole life. And today I'm joined with
I'm Priest Martinez, and I do management, and what I do is I give the travel aspect, you know, for Northern Circle, being a tribal member of Red River Valley Rancheria, and also that life's work of, you know, going through Mendocino County and getting some services from, you know, all these different services that we have. And I just want to recognize RCS and, you know, the organizations that were here. Jackie, like, without these things, we've been doing business for 40 plus years, and I think last year was the first time we ever combined something with the county and organizations in town to try to tackle these situations that we're going through. And you know, we want to be a part of the bigger picture. Tribe's been around here forever, but you know, being in business for 40 plus years and having a seat here, I think it's an honor, and I just want to say thank you for allowing us to be a part of this. And I know the tribes are very excited about having a future with the county. Thank you.
next slide. A A little bit about who we are as an organization. Northern Circle was established here in Ukiah in 1979. We're a tribally designated housing entity. And what that means is that a federally recognized tribe, through resolution, appoints Northern Circle or any housing authority as its tribally designated housing entity to administer specifically its HUD grant. Our primary funding source is funded through HUD. It's called NAHASDA, and that's the Native American Housing Assistance and Self-Determination Act of 1996. It comes through the federal government to HUD, through to the Office of Native American Programs, in which we administer on behalf of 9 federally recognized tribes. Now, as a TDHE, we offer technical assistance, we offer advocacy efforts. We're a property management company. We do affordable housing, we do community development, and we do social services. Our goal and our work and our vision at Northern Circle is to provide hope, healing, and housing. Now, when a tribal member comes to Northern Circle, we can serve them from homelessness through to homeownership without them leaving the office. There's not many programs where you can go and have full services, holistic, culturally relevant, culturally significant, client-centered, community-based services without even leaving the organization. We currently serve 9 federally recognized tribes. There's 5 in Mendocino County. We have 1 in Glenn, 2 in Oroville, and 1 in Sacramento. Next slide. I wanted to take the time to honor the tribes within our consortium here in Mendocino County. We have Giddyville, Hopland Band of Pomo Indians, Manchester Point Arena Band of Pomo Indians, Redwood Valley Little River Band of Pomo Indians, and Sherwood Valley Band of Pomo Indians. These are tribes in your districts. These are tribes I hope you're very familiar with, where it's an honor to be their tribally designated housing entity and to serve them. Next slide. Our vision statement, just like RCS had mentioned, we work really hard to create strategic plans and work with our appointed Board of Commissioners to develop this vision statement. And NCIHA strives to be the catalyst in creating security and ending homelessness for all Native people through hope, healing, and housing. That is our mantra. That's why we come to work every day, hope, healing, and housing. We're driven to help tribal governments with the development of their communities, to do so in a way that is consistent with the tribe's social, cultural, and economic values, to alleviate some of the efforts of poverty by providing quality housing to Native Americans in Northern California. And, you know, we truly live by that. Next slide. So before I dive into our programs and projects, what we do and who we serve, I wanted to provide a bit of a snapshot. So I had mentioned that we, as a tribally designated housing entity, which from here on I'll just say TDHE, we are primarily funded through NAHASDA dollars, and that's authorized through Congress. It's not enough funds. It is an allocation in which we receive to support our membership, and the allocation is based upon a formula, and the formula looks at current assisted stock, and those are units that were developed prior to the development of NAHASDA in '96, but under the 1937 Housing Act. And we receive a small subsidy to maintain those units, and then the rest is based on need, where it looks at how many individuals within the tribe are low income, how many are living without water or power, how many are having more than 50% cost burden within their household. Now, there's this misconception that tribes are, you know, have casinos and they have all this money, and why do they need federal assistance? It's absolutely that misconception. And not every tribe is a gaming tribe. Not every gaming tribe sponsors a sports team. And we have tremendous numbers of homelessness, and not until recently did those numbers actually reflect in the point in time count, right? Because we weren't going out into the reservation. We weren't actually going out and counting where our tribal people actually are. So the data does not accurately represent. But back to the funding piece of it, we've had limited funding, and I will provide an example. Through Nahasda, one of our tribes gets $628,000 a year to do all of their affordable housing programs. Now, if we did no rental assistance, no property management, no homeowner, first-time home buyer programs, no homeowner housing rehabilitation, no housing case management, no affordable housing programs, we could build one house. That's not sufficient funds. So we've worked very, very hard to advocate for equitable access to state dollars. Now, prior to 2014, tribes did not have access to funds through the California Department of Housing and Community Development. It wasn't until 2014 that tribes got a $1 million set aside for low-income housing tax credits. Now, this program was developed in the 80s, yet tribes only got access in 2014. That's one program, right? In 2016, we got access to the Home Investment Partnership Program with the potential for one application, and the first year our tribe wasn't even awarded. It took from 2017 until last year for Northern Circle to develop a fourplex with Home Investment Partnership funds. And it wasn't until 2019 with the passing of AB 1010 that tribes had direct access to additional funding sources through HCD. So I wanted to provide that. I wanted to paint that picture because this next section will seem like, wow, Northern Circle has had these opportunities for many years, these many programs, many projects, but it's only in recent years. It's through advocacy. We fought hard to draft legislation for Senate Bill 1187, which was championed by Senator Mike McGuire. And that's the Tribal Housing Reconstitution and Resiliency Act, which was signed into law and will now be initiated through HCD. We're excited about an advisory committee that is coming to us in the next few months, in which we hope we get a seat. But that's just a snapshot of the barriers that we face in providing programs and services to our membership. Next slide. So as far as affordable housing, we offer property management. We offer maintenance for those units. Across the 8 of the 9 tribes that we have within our consortium, we oversee property management on 232 units, all low income, serving individuals at or below 80% area median income. We offer a tenant-based rental assistance program, also through our Indian Housing Block Grant through the Nahasda program. First-time home buyers, homeowner housing rehabilitation. Some of our projects underway under affordable housing include the completed Hopland Fourplex, which serves individuals that are chronically homeless at or below 50% area median income. We have the Darlene Tooley Terrace, which is named in honor of our founder, Darlene Tooley. It's funded with a grant through Day One Family Foundation, Jeff Bezos' Day One Family Foundation. It's 2 triplexes serving tribal members who have families that are experiencing homelessness. We are developing an intertribal elder village, which I'll talk about later on in this presentation. We have a 22-unit housing development in Butte County, utilizing federal and state dollars, and we recently submitted 7 applications toward the Indian Community Development Block Grant. And next slide. This is where I will turn it over to the incredible Priest Martinez and the services and programs that he provides.
So one thing that we found out through with limited funding is that housing needs the social service department to be able to collaborate to find the barriers for, tribal members, let alone housing first. When you come to our door, it doesn't matter who you are. We're going to find a solution for you or try to find you the right services. So in our department, which we just built over 5 years ago, is the social service aspect of, bringing disability. How do we get the homeless people that are on, on unhoused, how do we get them to get income in order to apply for an apartment through through the low income apartments that are in this county. So we had to find them income, and then through Home Safe, that is our elders, or in our disabled family members that need the services that we try to provide for them. Bringing Families Home is our families that are in ICWA cases and CPS cases that we try to help support to bring them back with the family back together. And then we also had to figure out how we're going to help with individuals that are out there overdosing, which is suicide in our heart, in our mind, that we need to find a way to try to bring back the harm reduction part, bring services for that and actually get them into the place that they need to be. And then the Tribal Homestead Housing Assistance Program, that's our HAP, and that's our our little bit of supportive services that we get. We only get a dime of HAP money from from the state, and we utilize as best as possible for as many tribal members as we can. We usually, it's a 5-year grant, but we run out within 6 months, the majority of the time, for the services that we give, whether it be rental assistance, moving costs, whether it be paying a utility bill, all the services we can. In client transportation, with Kelly and I, we were allowed to utilize our transportation services, through the ESG services that the vans they provided us, that we just keep report on. We are definitely blessed to have the ESG at that time. And the most important thing that we find out when we do our groups is we need to teach financial literacy. Financial literacy, a lot of our tribal members, a lot of community members have evictions and they don't have savings accounts and they don't have a bank account. We have to give these, credibility back to these individuals that want to move into places, want to buy homes. In the cultural aspects for tribal members is important, is to believe in God again. And I bring that up because this is this truth. Right, we got to have something to believe in, whether it's another religion or another. We just believe that, cultural, events and cultural places that people believe in for our tribal membership, let alone anybody that wants to be a part of it. We have to have that aspect. Housing navigation is important for us. We are in the same boat as everybody else. There's not enough rentals out there in this county, so we try to resource with the owners of other apartments, other counties. We have to go above and beyond to get off waiting lists. I think the waiting list for majority of the places here are over a year. Behavioral health building, bridges, housing. So that is our services for homelessness, substance abuse, alcohol, marijuana. We got to get them treated. We work hand in hand with URC. And that's where we came about with the 24 beds for the SLE and collaborating and bringing together, braiding funding. It's the new term that we need to utilize today because we can't do it on our own. URC couldn't do it on their own. We had to do this together, so we utilized the BHBH and then being able to, afford treatment for individuals that don't have no type of funding for those services. And street outreach is really super important because a lot of people can't afford to buy their ID, their pay for their insurance of their car, gas for their car. All these little barriers that we had to dictate in a goal sheet. We have to have the street outreach in order to provide services. And community engagement is we have to bring our services to every place that we can in this county. Whether it be all the way in Round Valley or to Point Arena. And I say this all the way, it's from one part of the county to the other. It's not just Ukiah. This county is home to us. And so in order to provide services, we got to go every day. Either we're going over this part from the county, from the part where nobody goes, to the other part where nobody goes. We got to provide services because there's people everywhere in this county. And so that's for us is the most important thing as social services is to keep bringing, more organizations together.
And next slide. We have a really exciting project. This is the Intertribal Elder Village. We received an award of nearly $10.6 million through the California Department of Social Services Community Care Expansion Program. It was the first time that a tribal entity had been awarded through this program. Northern Circle received an award along with our partners down in San Diego County, the Paula Band of Mission Indians. we were able to leverage funds for the development, including philanthropic donations from U.S. Bank, and we received a few grants from the Federal Home Loan Bank. Phase 1 of construction, which is going to start in 2026, includes 15 units. We have them in clusters of 2. There is 1 single unit. They're intended for Native American elders. We have them accessible so that they can age in place. They're 2-bedroom, 2-bath. There's a large green space in the center of our development that will provide space for culturally relevant plants and herbs. We'll have an arbor. We have walking paths throughout the entire community, which will be lit with solar to ensure that our elders are safe as they walk. There's going to be some play space for the youth that come to visit our elders. Phase 2, which is still under planning development, we are creating a cultural and wellness center. This is a proposed 4,000 square foot building with an industrial sized kitchen, dining area, library, maker space, and office and meeting space. We received, again, a federal home loan grant award of $150,000 to support the planning. We are actively fundraising, and we really want this project to be the hub for our elders, to be the place where our youth can come in and learn from our elders through culture, through language, to have a safe space for them to age in place. And by developing these types of projects, we're creating a 2-for-1 opportunity with the idea that if an elder is living in an overcrowded or substandard unit, when the elder leaves to the elder village, we can rehab those units and turn it over to additional affordable housing for families or other individuals who are experiencing homelessness. This is going to be built at 420 Cooper Lane, right here in Ukiah, and we really appreciate the continued support of our community members, our tribal members, and many of you on the board. Next slide. So our partnerships working within the community. Next slide. Jackie spoke very beautiful about our partnership and how Northern Circle worked really close with URC to get this 24-bed development built. And actually, I thank Momo Heron for coming to us and having a conversation as well, and linking Northern Circle with Jackie and creating, beginning that relationship. And those are the types of things we need within our community. See a need, fill a need, right? If you know that there's a potential for 2 people to be able to work together and to partner together, we have to have those conversations, because we support twice as many people, 3 times as many people by those collaborations. Northern Circle, Pri spoke on it earlier. Northern Circle received a $5 million grant through Behavioral Health Bridge Housing. We offer short and mid-term rental assistance, auxiliary payments, outreach, and engagement. And we did have approximately 2.6 that we had contributed to the Ford Street project as gap financing. And I think the thing that really brought us together was our shared values and our shared goals to increase access to Native American populations. Jackie had provided extensive data about how many Native Americans are served through the Recovery Center, and the cultural inclusion that this space will incorporate with local tribal leaders. And I think the thing that really was the icing on the cake was for us to have a seat at the table and to have a seat on the board for the project.
I just want to add that the most important thing is to collaborate for wraparound services. You know, without us communicating together, you know, utilizing the COC, utilizing, you know, being on different boards that we don't have attention at sometimes, I think that's one of the greatest things that we could do is, like, we talk about these things about how we're communicating, but I also just want to reiterate that We work for the people that need our support, and I think that's the most important, is to continue to keep growing, you know, based off this SLE and get another facility. We'll start working on the youth. Let's start working on elders. Let's start working on, you know, more services. So I just say the wraparound services is starting for us to be a part of it is huge.
We had applied for 7 Indian Community Development Block Grant applications to conduct housing rehabilitation on 7 rancherias. We are going to continually actively fundraise for the Wellness and Cultural Center at the Intertribal Elder Village. We applied just at the end of December for the SOAR program, which was open to recipients of the Behavioral Health Bridge Housing. That's our transitional youth program that we hope to expand on. We're going to continue homebuyer education. We look forward to our Goal Setters financial literacy programming that we have at Northern Circle, and we will be hosting our 2026 annual big time event here in Ukiah, and we really hope that you can attend and be there to enjoy the cultural event and more of the community. Next slide. Want to learn more? Here's how. Visit our website, northerncciha.org. We're on LinkedIn, Facebook. Come down and visit us at our office. And I would like to invite the Board of Supervisors to attend our annual meeting, which is held February 28th, a Saturday. It will be in Butte County. We will be honoring the relationship we have there with Butte County and the development we are creating, the Mighty Mountain Line housing development. But we will also be highlighting and showcasing a lot of the work we do here in Mendocino County with our 5 tribes here, and would love to have you. Thank you.
Okay, thank you. Any questions from the board? I'm not seeing any. Thank you, Ms. McGill, for accepting the invitation. Just as well, a member, last time I checked, important, so thank you. Thank you. All right. Centers. I see they're in the room. The it's important to have lunch straight away at 12.
Yeah.
Yeah.
Keep going.
Okay. We have McCavin House. Miss Olson. Welcome. Thank you for being here. And if I could just ask you to try and stick to your 15 minutes, if you could. Thank you. So please. Thank you.
So before we start with the slides, I'm just going to give a very brief verbal introduction about McCavin Care and Prevention Network. The services began around 1987, and primarily they served victims of HIV/AIDS. All of the services were provided by volunteers. Over time, it was recognized that more needed to be done, and so the harm reduction program was developed and initiated. And that's what we're going to speak about today, is the contract that we have with the county primarily, and a little bit more work that we do where we garner funds to support the county contract. Specifically today, what we really want to talk about with you is we want to address the data, because the last time we met with the Board of Supervisors, there were some questions about data. And we went back to our agency, worked with our team, worked with community partners and the community at large, and our new data system, which is REDCap. And we've brought to you some interesting numbers. So first of all, what we wanted to share with you, and I am Joanna Olson, I'm the Executive Director for those of you that don't know me, and this is Joe Ditto. He's the Program Manager for the SSP and the HCV contract through the county. So over the last 6 months of this contract only, we have served 7,723 individuals countywide for harm reduction services, which is syringe services and supplies, HCV testing, HIV, and Hep B testing. We also provide other services like wound care kits, hygiene supplies, and Joe will speak to those. Interestingly, we're going to talk about the syringes out and the syringes in. Syringes out refers to those syringes that we provide to persons who use substances. During this period of time, there were 46,446 syringes distributed. Syringes in, that refers to persons who use drugs directly giving us syringes back. There were 34,530 syringes received, which is a 74% percentile. What I want to share with you is information that Joe has received recently from Raven, who's with KSEP and COFRE, that usually across the state of California and nationwide, 50% is a norm. So we're doing really well in Mendocino. But as a result of the last meeting that we had with the Board of Supervisors and public viewing, the discussion, we did get some pushback from people who don't support syringe services, of course. But conversely, we received a lot of public support from our partners and individuals in the community who worked with us to bring in more syringes. So under Community Out, there was 1,260 syringes that were distributed, and 600 were brought in. Okay. Oh, excuse me, I'm wrong. That's for December. The total was 1,770 out and 9,137 in. The combination of the community syringes and the agency interaction syringes brought us up to a 90% percentile for the 6 months. Now, do I think that can reasonably continue? It'll waver. You'll see in the graphs that we show you that the numbers will go up and they'll go down. But with more public awareness created through our Facebook pages, social media, I think that we can pretty much remain consistent with those numbers, and that's remarkable. So I really want to thank the Board of Supervisors for initiating the conversation about how can we do better, what more can we do, and it's evidenced in the overall numbers since the last time we met with you. I also want to share with you, which is part of our contracts, is the HCV tests and clinic referrals. So we had 52 tests. That may not seem like it's a lot. We'll talk about that in a minute. And 25 of them were referred to HCV clinic because they tested positive. In a conversation with Akesh Aidi, who is our program administrator, he shared that it looks like roughly McAllen has about 50% of all positive tests countywide, which is remarkable for one small agency to be able to get that type of an output. There's more data on here, and I'm sure you have this in front of you, but let's skip down to, because I want to be mindful of the time and allow questions from the board and give Joe some time. Let's skip down to Narcan distribution. We gave out 967 units of Narcan and 534 of naloxone. We're going to show you in a slide about, no, I don't believe we have the overdose information with us today. And Narcan out to the community, 1,282. There's an asterisk. 668 of those units were directly provided to the public at Pumpkin Fest. So part of our work that we do at McAllen is we go out to the community events, we provide Narcan distribution, training, and other supplies. We don't provide syringes. and we provide information and referral to people. And that's really important to get the information out about what it is that McCavan does. And it reduces the stigma of a syringe exchange and the bloodborne pathogens education that we provide to the community. Joe, is there anything you'd like to add about the data that we have? Great, okay. So the next slide, please. Which would be the total number of people served. See it up yet. I'm going to go pretty quickly through these slides so that we can open up conversation. Okay. So we start off in 2022. That's about the time frame that I joined the agency, and you can see that over the period of time through 2025, we've served considerably more people. Next slide. It's important to note the funding is near, which is the California Opioid Prevention Harm Reduction Initiative, which is under Sierra Health Foundation and funded through the California Department of Public Health. This next slide is a graph that shows syringes out, in and out annually. It remains pretty consistent, right? It's important for the board to note that there is constancy in the work that we've been doing in your communities. Next slide. Here's where you see a little bit of variance over the years from 2022 to 2025. Now, 2025 looks like we have fewer syringes going out. We'll talk about that in a minute. And fewer in. In reality, what you're going to see there is that it is actually percentage-wise consistent with our years prior in the 70 percentile range. The difference is that we started handing out glassware, not funded by the county, but through other funding sources, which reduced the syringe output by 25%. Now, the importance of glassware is that people have less use of syringes, which further reduces bloodborne pathogen spread. The next slide, please. What's interesting about this data, and I thank Akish for providing it, is that over time, from 2014 to 2024, with a syringe service in your county, look at the rate dipping down of HIV and chronic HCV in Mendocino County. That's in direct correlation to these services, and that's important to note, that syringe services work. Next slide, please. This again is about the HCV rate per 100,000 and the McCavan HCV test referral rate per 100,000. We contribute greatly to your communities. Referrals and testing is the next slide. It's for HCV testing and referrals to HIV testing. What the board may not know is that within McCavan, we have a MAC clinic. The MAC clinic provides recovery services, but we also do HCV cure. Our partnership is with Adventist Health, who provides the services of our lead physician, which is Dr. Ace Barish, and also the residents in their residency program. Without that partnership, which costs no money to the county and no money to McCavan, we wouldn't be able to provide the HCV cure. And it is the syringe service program that brings those clients, tests those clients, the positives happen there, and we bring those clients into the MAC clinic of McCavan. So the MAC clinic and the SSP work jointly together. All of the staff that are in the MAC clinic are trained to do syringe service programs. That's where they've started off in their role. Many of our staff actually came to McCavan through community services in agreement with the adult drug court, where we trained them, vetted them, and they started their employment back in the community in our exchange. And at this time, what I want to do is offer Joe an opportunity to talk about work that he does in the exchange and the work that he also does throughout the state of California and nationwide to bring supports back to this county for our Syrian Service Program.
Yes, hello, my name is Joseph Ditto, and I am the program manager at McCavan's SSP. Majority of the work we do is with direct services with individuals in the community experiencing homelessness, substance abuse, use, and trying to get them to the pathway that they would like to live their best lives. Now within that, we work closely with community partners, local tribes, and other agencies to provide that. Our area of coverage, we have a brick and mortar site in Ukiah, but we go to Covelo, Leggett, Piercy, Fort Bragg, all down the coast to Wallala and Anderson Valley and inland. Through our SSP program, we provide testing, ID vouchers, syringe cleanup, linkage to other services at our door and out of our mobile unit. And we also have a lunch day and food pantry now that the community has been stocking to help feed individuals. Some of the work I do with the state is through KSEP, which is the California Syringe Exchange Programs. I sit on a steering committee. I also sit on the Policies and Procedures Committee. I also work closely with the National Harm Reduction Coalition to bring back as much information that changes nationally, along with the National Harm Reduction Advocates to continue to strive for the best solutions possible for individuals experiencing substance abuse and substance use. I work closely with the Drug Policy Alliance as well, helping to reform laws that have brought stigma to individuals who actively use. And I'm also part of the California Department of Public Health Harm Reduction Huddle, where I provide information and barriers that we experience in Mendocino County with our participants. Within our agency, we have a unique skill set reaching individuals. I've had the luxury of working the SSP now for 5 years. I came to McCavan as a housing navigator. One of the blessings I've seen through our SSP is that individuals come to the door, and every time they come back, they look for a different service. We've been able to get individuals housed, get them treated, transport them to treatment facilities, send them to URC, and then they find a way of life that they can find happiness again. And we recently received a letter which was heartwarming because the work we do matters, right? Go ahead.
Me. Thank you. An exchange that after we stay like a better area and things from I moved able to start anew much easier and only a little over an hour away from my parents' place, who I now enjoy a very close relationship with and get to see often. I wanted to take the opportunity to thank all of you at McCavan who literally jumped through hoops and went way above and beyond to help me find my way back to a life that had become a faded memory that was completely impossible to ascertain to me. Without all of the amazing care, unending empathy, and love that I was given by all of you, none of this would be even close to possible. All of you, in more ways than one, saved my life. Forever thankful, X. This text comes at the right time. With everything that's going on throughout our nation right now, And with reduced funding and a reduced team, we find ourselves often low on fuel. And what I mean by that is that this is difficult work. This is hard work. Our team went down into the creek last week and naloxoned a person down there and saved his life. And this is hard work. We face adversity, we face stigma for the work that we do, but we save lives. This is important work for our communities. So when we got this text from X, our tanks were refueled, okay, so to speak. Our tanks were refueled. This is why we do this work. Exactly why we do this work. This is why we meet them where they're at and provide the syringes and the supports that go with that, so that hopefully we're able to bridge them into their next form of treatment and give them their life back. They become the person they used to be. So we want to share with you something lighthearted but important, which is the next slides, which is some of our social media posts, and then that will be the end of our presentation and you can ask questions. So next slide, please. Primarily social media is Facebook, Instagram, and TikTok. Oh, Blue Sky. We share posts from National Harm Reduction and other sources because they're vetted and put out. And this is 5 reasons harm reduction is the best approach. It's educational to the community. Next slide, please. Narcan, always carry Narcan. Again, educational. People know where to get it. Next slide, please. But I don't use drugs. This speaks to how people can have something happen in their lives even if they don't use drugs, and why it's important to have Narcan available. Next slide, please. HIV and Hep C, why it's important to test. Education of the community. Next slide, please. This is an actual Narcan kit from McCavan. That's Joe's work. Next slide, please. I like this one. It really says, let's talk about it, okay? When it's blown up, it's pretty educational. And I think that's the end of our slides. Are there any questions from the board?
I'm not seeing any.
Huh?
I'm not seeing any. Supervisor Williams.
I wanted to thank you. It was one of the better follow-ups. I appreciate the data. I mean, I think you made a convincing case. I supported Chair when he pulled the item to have the discussion, but these are exactly the answers that I was hoping would come back.
Great. I wanted to circle back around to the last time we met.
Supervisor Haschak.
Yeah, thank you very much for the presentation. I hope that you frame that letter, because that's what we do
It's
this kind of work
important.
for.
You know,
right?
the data is good, right?
Right.
But this is what we do it for. And so when this came in, I went, they got to hear this.
Yeah, very powerful.
Yeah, this is what we do it for.
Okay. Well,
Thank you.
very much, both of you.
Thank you.
All right. Next up, we have first 5.
Going to give you some very fun things to think about. Children and families, right? Okay. Good afternoon. My name is Townley Say. I'm the Executive Director for First 5 Mendocino. It's so good to be here. There is a presentation. She's going to load it. But before then, I just wanted to ask a couple of questions about the first 1,000 days of a child's life. Have you heard about the importance of the first 1,000 days of a child's life? How long do you think 1,000 days is? Any guesses?
3 years.
Just under 3 years, John. Thank you so much. First 5 Commissioner, very, very informed. Thank you very much. 2 years, 9 months, yes. And in that time, serious brain structure of a child happens. It's a very, very sensitive period in a child's life. The heightened brain plasticity in infancy creates a disproportionate influence on well-being, meaning it impacts the rest of their life. And you have been privileged today to listen to a lot of nonprofits here serving a lot of different high needs in our community. And what I'm here to say is any attention that can be given to prevention and intervention for a child's life is going to set up the next 20 years for seats that are going to be filled by the future children here now. So I'm sorry if my voice is shaking because I always get nervous when I'm talking, so sorry. But understanding how the architecture of the brain works is very essential, and understanding the lifelong impact of that. So I'm going to talk about a program. It's called the Triple P program. Every January for the last 4 or 5 years, you guys have been accepting a proclamation in January called the Positive Parenting Awareness Proclamation. You may or may not know that Mendocino is the first county in California to bring the Triple P program. I don't know if you knew that or not. I also don't know if you know that First Five really isn't a nonprofit, but we act as a nonprofit. We are a state-funded agency from Prop 10, which is a tobacco tax that, rest in peace, Rob Reiner and his wife worked to instill a funding structure to ensure that the first 5 years of a child's life had supports in place in every county in California. But it is a declining revenue source because it's tobacco. And we're always working on tobacco cessations because we want children and adults to live long, healthy lives. But one thing that's really important about brain architecture is the serve and return. So that means that when a child smiles or makes a coo or laughs or has any kind of discomfort, there's a caring individual in front of them that can return and respond to that. And what we've seen in the breakdown of our community is adults who are having children and they do not understand basic, typical child development. They're putting a child in front of a screen a lot of times. And this serve and return is becoming less and less common and less available to children who need it for critical brain development. And so I really just want to highlight these few things, and then we'll get into some of the Triple P data, that this program really provides hands-on skills to parents so they can learn about how best to support their children as they grow into adulthood. So some of the barriers, and you've heard them today, to early relational health, and you'll hear that term a little bit more, I'll use that more often, is some of the barriers today are cultural and generational factors. This is how I was raised, this is how I'm going to raise my children, right? Without really understanding the responsive care principles of how to respond to that serve and return to a child. Social economic pressures, lack of support systems. We've seen a decline post-COVID of all of these harm reduction programs we had in our community not in place, and we are seeing the serious effects of that. And limited knowledge of infant behavior, and a lot of parents, adults not understanding their own childhood trauma so they don't keep passing that on through generational pieces. So really understanding that. I know I'm sensitive of time. So what we're working on is really trying to develop these protective factors. There are 4 main protective factors that this program in particular covers: is parental resilience, social connections, which every nonprofit here that you've heard today has been actually continuing to kind of elevate, is how important it is to have somebody to walk alongside of them and have that social connection. Keeping those intact in a rural community are even more difficult because families move. There's geographical differences between families. Experiencing concrete supports and times. Again, all of these programs that you've been hearing today offer a lot of those concrete supports, Triple P and First Five as well. And then finally, just a general knowledge of parenting and child development. Can you go to the next slide, please? So there is a disturbingly large number of children who develop significant social behavior and emotional problems that are preventable. And when I'm saying they're preventable, it's by that early prevention intervention. Is it a mandated service? Only in a couple of areas. Department of Developmental Services makes sure that money comes down from the state to counties to serve 0 to 3 kids who might have a developmental concern. Those are identified through maybe early screening or what have you. And I think, I don't even know what other mandated services are really that are prevention intervention. It is really anything that the counties can do. If there's any money, we're receiving money from the Mental Health Services Act that funded a lot of these services. With the changes from Prop 1 to behavioral health services, those prevention intervention dollars are being taken away from county levels and being sent just at the state. First Five Association is working with Department of Health Services to bring those back actually down to the county level. So that's part of our advocacy work from the county level up to the state work, because we understand that those need to be boots on the ground services, not campaigns that direct constituents to go to a website. So next slide, please. So this statistic is been reproduced from 2000, 2010, 2023. It keeps coming up as the kind of the general statistical range of the percentage of children who actually have emotional and behavioral problems that are within a clinical range. It's kind of a small percentage. And when you look at the larger picture, but if we stop serving and stop providing really prevention intervention service to this non-clinical, you're going to see that clinical range continue to grow and continue to be an economic stress on counties. So I just wanted to bring that up to you. Next slide, please. So these are the 5 core areas of what PPP does. And so when a parent receives PPP services, and they can be light touch services, they can be something as acute as a parent having problems with toilet training or sleep training their child. They can have problems where they need a whole suite of skills to understand, what is my child going to? I don't understand how to give them constructive feedback or what have you. These 5 skills are ensuring a safe, interesting environment, basically saying, do we want to have a child who only lives in a house that says, no, don't touch that, no, 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 no. We want to help parents create an environment where they can actually say yes to their child. This is okay, this is safe. It's safe for you to explore this, and that's a boundary. Here's a healthy boundary. Having realistic expectations. What can they ask of their child for them to receive and be able to be like, okay, that child can sense success in completing a task because it was a realistic expectation. Is it a realistic expectation to take your 2-year-old to a restaurant in the middle of dinner time? Probably not, right? So supervisor client's like, no, I don't think so. It's not realistic because they're probably going to be tired. They don't understand the realm of the restaurant or what have you, right? So we teach parents to be set up for success, and so that I can actually enjoy parenting their child. Using assertive discipline, basically noticing when they're being good and calling that out, and then having consequences that are logical. Creating positive learning environments, and then this is the hardest thing for parents, is taking care of yourself as a parent, because the mental load and the mental labor that it comes in with caretaking, you have to take care of yourself because you cannot give from an empty bucket. Next slide, please. You can read this on your own time. I'm not going to go through all the data because there's lots and lots of data, but this program has 4 key areas of research that have been really, really instrumental in how effective it is. Conduct problems. Have we heard about conduct problems in school? Do we have that in Mendocino County? Yes, we do. This program can address it. Oppositional defiant disorder, disruptive behaviors, ADD, hyperactivity disorder, anxiety and emotional problems. We've seen that here. And prevention of more severe disorders. So there's lots and lots of research to support this program. So I know you guys like data, so I brought a few data slides too. Next slide, please. Yes. So this data is from 2023, 2025. I could have brought you post COVID data, but it was not really very good because a lot of parents were in the house and we were providing everything online. Everyone was transitioning. So I thought these 2 years would be great. We served around 400, about 200 parents, families a year. So for this data set, it's 400. It's all weird because you know when you take something from a PDF into a publisher and all the spacing. So excuse the poor formatting. I apologize. But the key findings are this program dramatically improves parental consistency and reduces harsh discipline. So we're going to see a lot of those family children services calls in for like being, physical abuse, what have you. This program really helps to reduce that. Significantly enhances parental mental well-being and critical foundation for change. So you talk about change. What's the key point, right? Understanding and then having control over how they respond to their child in a way that's effective is transformative for parents because they feel like, oh, I finally got this. Now I know what to do. Fosters warmer parent-child relationships and more positive family environments, and effectively reduces acrimony between separating parents. So we've used this a lot in divorced parents so they can co-parent better so they're not using their child as a negotiating tool. Very, very important. Next slide, please. So this is just some of the data. So you can see before parents are taking the so just for your information, when a parent comes into this is from an 8-week parenting series. Before the parents start the survey, the series, they take a survey. They rate themselves. This is a self-rated survey. At the end, then they do the same survey at the end of it. So these are the pre and post results of those findings. So the first one that we measure is parent consistency. How consistent is a parent? When they say they're going to do something, how often are they following through? Huge improvements in that. Coercive parenting. Huge reduction of that. The green is the after. So before a parent is taking the class, they don't really kind of understand how they can effectively, they may be spanking their child or maybe slapping their hand or what have you, or maybe even using like words that are kind of slightly kind of abusive. So the coercive parenting has significantly reduced, about 50%. Next slide, please. Parent-child relationships has dramatically improved. This looks like parent satisfaction. They are actually enjoying being a parent. They're actually getting the stress of being a parent is really significantly reduced. Positive encouragement. They know how to identify. Most parents catch their kids being bad. My kid's always doing this. They're always doing that, whatever. We teach parents to catch their children being good and noticing those good behavior, and then how to give appropriate praise to that behavior so that they repeat it over and over and over. And so that creates more positive encouragement as well. And next slide. And this is the parental adjustment. This is a big, huge increase as well, and it really reflects on parental stress and depression and anxiety. So for those parents who are just feeling really anxious or overwhelmed, this program has improved those outcomes as well. And then finally, this is, every program has their area of improvement. This is one that we're focused on in Mendocino County, or First 5 Mendocino, is really working on parents, that co-parenting piece and teamwork. We would like to see this one be a little bit higher, but we are seeing improvements in it. So last slide, please. And then you guys can go to lunch. So the conclusion is, there's clear improvements, and this program has been showing clear improvements in parents' lives. We recommend, obviously, to continue to fund it. We have 2 contracts right now, one through Family Children Services and one through Behavioral Health Services that fund this group. With the changes in Prop 1, the Behavioral Health Services funding will probably be ending. So the new RFP that was released did not include offering parenting supports in that area, so we did not renew that RFP. So in the light of declining, to Prop 10 funds and what have you, I would really like for you guys to just consider, like, where can we find prevention and intervention dollars to maintain this program in the community. I really want to thank John Hashak and Mo Mulheron. They have been 2 of our commissioners alternating on the First 5 Commission board. So thank you for always your invitation. And I really wanted to make sure that you guys had some data because I think the whole board could really benefit from understanding the effectiveness of where your county dollars are being invested and to show you that they are being well invested with this program. So just thank you for also always annually accepting the proclamation, and thank you for all the nonprofits that show up every day for our community. I'll take any questions.
Okay, Supervisor Haschak.
Well, thank you for the presentation, and really for the people out there who they held, certainly do whatever program, because county high level
do.
Child.
And I could on a. I feel like if you're going to also need sides of the same. So thank you for bringing that up. So all of our classes are free, and that's because of a lot of the county funding that we get. Now, there is a lot of advocacy work being done with the CalAIM extension that we could actually use CalAIM dollars. We are now starting to draw in CalAIM dollars to provide some of those services. But again, there's a lot of parents who don't have partnership, and it's only through partnership that it would be eligible through First Five. But right now, they are free to any parent, to any caregiver, to grandparents, to foster parents, to resource parents, if you're in a caregiving role. If you're not in a caregiving role, if you want to learn about how to have better relationships, take a Triple-P course. It will be best. It's great. Thank you.
Supervisor Williams.
I hope you come back and drown us in data. That was excellent. Where can the public learn more? Do you have a website?
First5mendocino.org. Please join us, yeah. And if you have families that need resources, we have tons of programs. This is only one program that First Five Mendocino does. We have a Welcome Baby program that is utilizing CalAIM dollars to really create wraparound services to families as soon as they become parents. So right from discharge of the hospital, we would like to connect with parents.
Okay, I don't see any more questions.
Okay.
Thank you very much for being here.
Thank you.
Appreciate it. And we will break for lunch and come back at 1:10.
Yes, I do. Oh.
everyone. Summit, Service and Health Service, White, please.
Afternoon, members of the board. I'm Stephen White, the assistant. And today I am and Voorhees, the of the Deputy Director of Employment and Family Assistance Services. We'll be providing you a brief update on what's happening in social services. We'll start with Rachel, then move to Jesse, and then I'll close with a couple things I have to mention at the end.
Good afternoon. We're here to give a little bit of update on some of the efforts that the department has made, as well as some updates that we have received from the state regarding some of the impacts to our programs, specifically related to health. When we were here before, I think we gave a very detailed timeline of when the impacts of the California state budget in HR 1 were supposed to hit. So since that time, we have been working diligently on outreach. We have done a press release for the changes that went into effect January 1st, which were the asset limit reinstatement and the full scope freeze for certain populations. The state has actually, Department of Healthcare Services has sent out mailers for both of those impending change, or both of those changes that have been affected as well as some text messaging campaigns. For the department, we actually do regularly make posts to our social media page. If you don't already follow Mendocino County Social Services, I highly recommend it. Not just for members of the board and community partners, but for the public as well, because we will regularly post updates, important updates to the programs, but also some outreach efforts. For example, we do try to make it out to Covelo every month to help with application support. And we will post for members of the public so they'll know when we are going to be there. And that's usually at the Round Valley Library. So I think that's one of the efforts that we're trying to make in order to keep people enrolled and to help people get enrolled. We also have hired, since the last health summit, we've actually hired 9 new eligibility staff to assist with making determinations, keeping people enrolled, and enrolling people newly in services. We have a new eligibility induction training class that just started on the 5th of this month. We've provided quick guides to our staff, and we've also done some training for staff on the impending changes, or well, the changes that have already gone into effect. And we are working on training for the changes that are yet to come. As far as the community engagement requirements and the 6-month renewals for Medi-Cal, we just recently got the guidance from the state on those at the end of December. And while you know, we do receive funding and we do operate programs based on requirements set forth from the federal government, the counties actually operationalize based on the guidance from the state. So you know, we really do depend on getting updates from the state before we're able to implement programs. I just wanted to also just give a little update on our enrollment for Medi-Cal. So as of November, we did have 36,628 county-administered Medi-Cal beneficiaries, because there are some beneficiaries that we do not administer if they're purely through Social Security. And for the upcoming changes, about 13,000 of those individuals are going to be subject to the work requirements based on just specifically their aid code. So that's just an initial analysis prior to looking at potential exemptions. But that's about 38% of our caseload. So I just wanted to highlight that. For the asset limit reinstatement, a little over 6,000 of our Medi-Cal beneficiaries are subject to that. And those assets are required now at any application submitted effective January 1st or at renewal for existing beneficiaries. And, you know, then just really waiting for, we have not yet been able to see the effects of the changes because they just started January 1st. But the Department of Health Care Services is required to provide a quarterly report. And so, you know, we should be able to see probably after Q1 what the effects of that have been. I also would like to point out for members of the public and members of the board that the department actually posts data monthly on our department web page that is on the county website. So I think that would be really a good resource to look at because we will post historical data as well as the most recent updated data.
All right, thank you. Again, Jesse Van Voris, Deputy Director, Adult and Aging Services. I'm going to focus specifically on the impacts to the IHSS program and kind of how those interconnect with Medi-Cal. We have other programs in our division, but those are what I'm going to focus on. In terms of IHSS, it's a sub-program of Medi-Cal, so to get in-home support services, of course, you have to qualify for Medi-Cal. So any proposed changes or the changes that are coming to Medi-Cal are going to impact people's ability to qualify for in-home support services. And I think funding is what tends to drive changes at the state level. So when there's threats to the amount of federal funding, the state imposes changes to try and find cost savings at their level. Of course, historically, we've always tried to prioritize applications and change assessments to make sure that people get the care that they need, that they're eligible for, the in-home care, and then also when their medical condition changes, maybe they need increased hours. But at the same time, we have mandates for reassessments where we have to go out annually, whether there's a reported change or not, and meet with the client and confirm their continued need. One change that's come from the state level is the imposition of penalties for overdue reassessments for the Community First Choice Option Program. About 1,138 of the close to 2,500 cases we have for IHSS in the county are Community First Choice Options. We just call that CFCO for short. And starting in July, they started imposing penalties for overdue renewals. We've tried to shift our priorities to try and focus on those. Not that we've gained a significant amount of staff. We still have the same amount of workload, but you know, we needed to make sure and get those cases done to avoid the penalties. I can say that in the first quarter of fiscal year 25-26, we incurred $15,000 in penalties, which was a little bit less than what I had anticipated, which is good. We've had continued progress towards reducing those and returning to compliance. We're on track to have maybe $5,000 in penalties in Q2. But it's still close to $20,000 incurred to date that was not budgeted for. Some other changes coming at the state level with the governor's proposed budget that was just released in January. There's a proposal to remove growth funding from the IHSS administrative allocation. This just came out last Monday, so I'm still looking for guidance on how that's going to impact us, but we do rely on the growth funding. Historically, growth funding hasn't aligned with the actual growth we experience. We experienced 10% in caseload growth year over year, 24 to 25. The growth funding, they gave us 5% additional funding, but it was still about $100,000. And so losing that funding, which is proposed to be taken away in 27-28, could impact our ability to keep up with costs and the amount of cases that we're gaining, increased wages of workers. The other proposed change in the governor's budget is conforming termination of IHSS cases with Medi-Cal termination. Customarily, we've had sort of a fail-safe called a residual program where if someone's Medi-Cal gets discontinued because they didn't fill out the renewal paperwork, we would leave the IHSS on until the social worker could take a look, see if there's something that we could do to kind of push that renewal along before, finally, taking the action to discontinue the case. With this proposal, it would terminate the IHSS just on the same date that the Medi-Cal is terminated. So there's concerns, but of course the state is looking to reduce costs. And IHSS is a very costly program, but it's an important program. It keeps people in their home. Nursing level care is extremely expensive, and IHSS is more affordable caring for someone in their own home than having them go in a nursing home.
Okay, and a couple of other concerns that we're tracking. The first has to do with HUD funding. In November 2025, HUD released the fiscal year 2025 Continuum of Care Notice of Funding Opportunity, proposing significant policy changes, including a 30% cap on all annual renewal demand for all project types, including permanent supportive housing. Mendocino County's Continuum of Care funding has historically been almost entirely dedicated to permanent supportive housing. I'm just going to use PSH moving forward, rental assistance. If implemented, these changes would significantly reduce PSH funding beginning July 1st, 2026, and could result in the termination of rental assistance for a substantial number of households. Currently, 134 households in Mendocino County receive PSH rental assistance through the Community Development Commission. Under the proposed HUD policy, funding would support an estimated 40 to 50 households, placing approximately 84 to 94 households at risk of losing rental assistance. In December, a federal court issued an injunction temporarily prohibiting HUD from implementing these policy changes, allowing current PSH funding levels to continue at this time. While this provides short-term stability, the long-term outcome remains uncertain and subject to future legal and administrative action. Separately, earlier this week, a federal judge in New York issued a temporary restraining order halting recent federal funding freezes affecting Temporary Assistance for Needy Families, or TANF, the Child Care and Development Fund, CCDF, and the Social Services Block Grant, or SSBG. These actions followed reports of potential fraud associated with affected funding programs in Minnesota. County staff are actively monitoring developments and will return to the board with additional analysis and updates as they come in. And lastly, Rachel already mentioned it, but I would like to note that Mendocino County Department of Social Services maintains a publicly available data dashboard that is updated monthly, where community members can view the work that we are doing to support our some of our most vulnerable residents. That can be found at www.mendocinocounty.gov/departments/social services. That, do you have questions for us?
Any questions from the board? I'm not seeing any. Dr. Miller?
All right, good afternoon, Dr. Janine Miller, and I'm here to talk about health services, both behavioral health and public health, and our public guardians, public conservators office. So we've been watching a lot of what's happening at the federal and the state level. Some of the big things that we've been watching is, we spoke about at the last health summit that we lost our CalFresh funds for public health, and so we had some closeout funds that the state allowed us to utilize to really try to work with our community partners to see if we could do train the trainer models and try to maintain some of those services within our community by partner agencies picking up sort of those public gardens and really talking about healthy food and healthy nutrition. And so we've been working with a couple agencies on that. We learned in just the last couple of months that our oral health funds are going to be cut in half in 2027. So that is a program that really focuses on oral health in our community, especially for children and all levels, but really focusing on children oral health and working with a lot of our community partners to get information out there about oral health. So we're going to see those funds cut in the grant year for 2027 by 50%. So we'll be having to relook at whether there are additional grants that come out or how we see that program going, being cut in half in the next year and a half. We have been watching, obviously, Medicaid, Medi-Cal, to look at how's that going to impact, especially the behavioral health and substance use services. We know that there are potential changes to the FMAP, which is the federal Medi-Cal assisted percentage that we get paid. It's usually based on an individual's A code, and depending on whether it's a negotiated agreement with the federal government, we might get a different amount than 50-50. I spoke a little bit yesterday during the core presentation, a little bit about the mobile crisis response that was a mandated service that we had to roll out in the state of California. We started it early in Mendocino County because we applied for a grant, and we were awarded those grant funds to roll out those services across Mendocino County, and then California made it a mandatory service. We've been told that due to the changes at the federal level to the FMAP, that those will most likely by April 1st, 2027 become optional in counties and no longer mandated and won't be funded at the federal FMAP rate of 85%. And therefore, if counties want to continue doing mobile crisis, they would have to figure out a way to fund the additional 35%. Our association is working on that and going to be seeing what options we have. I think that it will also be a time that we'll be looking at whether we go back to Measure B. Measure B originally did want to fund mobile crisis response in Mendocino County, and so it's one of those programs we'll be watching to see if we go back to Measure B and ask for additional funding to keep that program going. There has been a lot of benefits with law enforcement and the community for mobile response and has reduced some of the 5150s. We're also watching the work requirement and how that's going to impact our beneficiaries that we work with. And I think the biggest thing we're watching right now is what happens with those individuals that can no longer qualify for full scope Medi-Cal. Full scope Medi-Cal covers mental health services at all levels. Limited scope does not cover mental health services at all levels, and so you would have a number of individuals who would not be able to get behavioral health services, and so they would be only get that limited level of emergency services. So prior to ACA, we did have some impact to our systems because we didn't have enough, we had people who couldn't qualify for Medi-Cal, and if we had someone that needed to be on conservatorship and was unable to get Medi-Cal or SSI, it would become a full cost to the county, meaning all pharmaceutical costs, all medical costs, all board and care costs, all clothing costs, all food and shelter costs. And so those are things we are watching. We're definitely wanting to hear more about CMSP, and I know they're talking today on what their plans are for covering those that are in the UIS, unsatisfactory immigration status, and what Medi-Cal, what kind of medical services those individuals may qualify for under CMSP. Lastly, we are tracking the governor's budget, as we talked about with the mobile crisis response change. We also know there's some proposals to the public health side. That association, CHIAC, has been really advocating. We don't want to see public health funding go back to pre-pandemic because we weren't prepared to respond to COVID. And so there's a lot of push from the state to really try to maintain our public health programs at the level they are today, and actually would like to see those improved, but there are some obvious proposed cuts in public health and behavioral health. And so I'm open to any questions.
Supervisor Haschak?
Well, I have a question going back to Ms. Elliott. That, you know, you talked about 36,000 being on Medi-Cal that we deal with, and then 13,000 having that work requirement. So in Mendocino County, probably not 13,000 jobs out there. So how do we deal with that?
Well, that actually has been risen, that has been a huge topic with the County Welfare Directors Association, the CDSS as well. We've had some listening sessions. There is a genuine concern about lack of capacity to ensure that people have opportunity to meet those requirements. So to point out, to be fair, it's not just work requirements. There could be other circumstances that would, or other things that would qualify or would meet, community service, volunteer, and then there would be some individuals who would receive some exemptions based on their individual circumstances. But because we're not just looking at our Medi-Cal population, we have a work requirement for CalWorks, our cash assistance families. We have a work requirement which will be implemented in California for CalFresh recipients starting in June of this year, and then the Medi-Cal population as well. So there is a genuine concern about the capacity of our workforce partners to serve the individuals and to have enough jobs for people. So it has definitely been a big topic.
So is the thought that there'll be a waiver if we don't have the capacity for these people to fulfill the requirement, or?
So the current waivers are based on the unemployment rate. There are, I think, there might be 6 qualifying counties within California who meet the definition of having high enough unemployment rate. Mendocino County is not one yet. But otherwise, there is not. Just based on the fact that there aren't enough jobs, that does not necessarily give a blanket waiver to the county.
Thank you.
I'm not seeing any other questions.
Thank you, you guys. Thank you.
Next we have,
You got to push the outside. There you go.
pardon me?
So now we need the clinics and the hospital
Are they all
and
here?
partnership health plan. Come on up.
Mendocino Coast Health Clinic, Adventist Health, Mendocino Coast Clinics, and Partnership Health Plan of California. I know. See how I did that? Quit letting. Welcome. Thank you. If you guys could introduce yourself. Thank you.
Afternoon, my name is Jeff Mock, Operations Executive for our Mendocino 3 Adventist Health Hospitals.
Welcome.
Lucretia Renteria, Executive Director of Mendocino Coast Clinics and the Board Chair of the Alliance for Rural Community Health.
Thank you.
Good afternoon. Buck Ellingson, Associate Director of Government Affairs for Partnership Health Plan.
Welcome. Thank you.
So I think if we could begin with the clinics, so Lucretia, if you and Rod would like to go first, and then we can go to the hospital, and then we can wrap up with partnership.
Great. I had prepared a few things to talk about in how these cuts, now that we passed the January 1st date, are affecting us. And I will tell you that we did a push on social media and other venues to try to make sure we got as many people into full scope Medi-Cal as possible. All of the clinics around the county were really working on those efforts of getting people to understand how important that December 31st deadline was, and we made that. We will see what happens in the fallout on July 1, when the dental benefit is cut from that benefit package for people with UIS and that aid code. That's going to be one of the biggest cuts coming up with our dental. So those of us that have FQHC status will be putting those patients on the sliding scale. For me in particular, that's going to mean a loss of about $200 of revenue for every dental appointment we have for anyone that's in that category. I don't know how many patients that is, because we don't track and don't want to track anyone's immigration status, and we don't know what the aid codes are that are assigned by the county or what the count is that would then be assigned to us. I think there are estimates county-wide, but we don't have them by provider at this point. One of the other things, and I will have to say that I've been kind of shook since last night, because I had been thinking that the federal cuts and the federal threat would hit us later on. And I apologize to my staff and the rest of my board that I have not been able to make this announcement to, but we lost about $400,000 in funding last night for our SAMHSA grant. So our medication-assisted treatment program was terminated on the day that they notified me, and they just said, this is your last day. You have to do all of the end of grant reporting, and or you don't qualify for other federal support, and your grant does not align with the SAMHSA funding priorities. They did not discuss which priorities they were. They didn't say what the SAMHSA funding priorities are. They didn't say what our grant and how it diverged. They said that at times they offer a suspension and a corrective action plan, but that they had no intention of doing that because there was nothing that we could do to correctly demonstrate that we would reflect the priorities of the agency. So we have a lease that has a 6-month clause in it before we can get out of paying the rent. We have staff that are hired to do that work. And more than that, we have 150 patients that we see in our Suboxone program that have now been cut off of support. Most of them have coverage in some way to have their medication ordered. We can shift, we can pivot. Community health centers are good at doing that. But some of those people do not have the money, and this grant was allowing us to buy Suboxone for them, to keep them having a grasp on life and being able to be functional parts of our community. We've had many success stories. We have a really solid program. This was a 5-year SAMHSA grant. It was due to end September of 2026. I knew I was ramping it down and creating stability plans for it and wanting to move our staff out of a building into another. But last night, this hammer fell on us. So I just wanted to let you know that as we try to plan and we try to look at these things, we don't know when we're going to get a surprise email from this administration.
Can I ask a question?
Yes, please.
And who was that letter from exactly?
SAMHSA,
What is SAMHSA?
sorry, the Substance Abuse and Mental Health Services Agency. They're a federal agency. For all intents and purposes, they have been dissolved into the AHA, which under RFK Jr. So HHS, the HRSA program, the SAMHSA program, all these programs that we get federal funding for. I will tell you that it makes me, I don't know, Rod, if you're afraid, but I'm worried about my HRSA grant. This grant was $525,000 a year for 5 years. We started our 5th year in September, so we're not, we did have some billable things back to the grant that have been covered and paid. We will lose part of that year's funding, but our federal grant is much larger than that. And I don't know, that this is tied to an executive order that as a convenience, they will change funding priorities without notice, apparently. Your turn.
And on that note, any other questions? Yeah, I think we're I think all in the same boat as in terms of the effects that just took place January 1st. We're still trying to measure what the impact of that is. I really appreciate the cooperation with the Department of Social Services and their efforts to beef up their ability to keep people on Medicaid and get them enrolled, and I know we've offered to help in that regard as in any way we can. So we're still waiting on that. I had the opportunity to meet with Jeff Mock this morning. He and I meet on a regular basis just to see how each of us are doing and where we can partner and work together rather than just looking at each other as competitors. Several months ago, just prior to the passage of H.R. 1, there was a lot of effort to try to raise awareness of what the impact of some of these things were going to be, including hospital closures and those kind of things. And I think at one point, every hospital in Mendocino and Lake County were on that list as potential closures. And it really created a lot of uncertainty for a lot of people about what the future of healthcare looked like. And I think both of us have agreed that we believe that the healthcare structure in the county is still strong. There are things out there. If we did lose the core funding for or if they were to eliminate the community health center program or something like that, it would be pretty devastating to healthcare across the country, really. But it would devastate those. I'm not feeling that pressure. I mean, I'm talking to some of the same people that, of course, that Lucretia is, but we haven't heard anything that our core FQHC, that's Federally Qualified Health Center, funding is at risk. As a matter of fact, we do hear talk of bipartisan efforts to maintain that service. So we do believe that we're going to be here for the long run, and I think that if what we're trying to focus on is how do we figure out how to take care of our patients and message to them that it's important to continue to come see their primary care provider even if they do lose insurance. And that's why we have things like our sliding fee scale, because if we don't, then 6-9 months down the road they end up in the hospital and they cost all of us tens of thousands of dollars more than what we would have been able to do for, if we can take care of them in a primary care setting. So that's one of the efforts that we're really trying to make is how do we get the word out to our patients and others in the community that, you know, we're here. And if you do happen to lose your insurance, we really think it's important that you keep seeing providers. So.
I actually have one more comment. I realized I was probably seeing red. I do want everyone to know that the California Primary Care Association had been contacted by our state attorney general to find out how many clinics across California are being affected, what the dollar amounts, what the patient load is, everything that's happening. The state of California very much may be looking at launching some kind of a suit based on this executive order action and these terminations. But it is certainly very, very hot off the press right now because we all just got notified last night. Pacific time between 6:30 and 11 o'clock, I received 3 different emails talking about this termination. So I'm hoping that the state, that not only our primary care association, but the state of California will be behind taking action on these grants.
Good afternoon. Good to see you all again. I wanted to just kind of recap a little bit when we got together last time. I know that there's been some news articles before we had gotten together about the concerns about what does it mean for hospitals within our counties. Just to kind of recap or want to talk about what it meant for us. A lot of that information went out as the bill was being passed or just before the bill was being passed. And the hospitals that we have in our counties were on that list. The real question you have to ask yourself is, how was this list of going concern for hospitals, how was this list created? And really, it was not individually on hospital financial performance. It was actually based on what's the percentage of patients that you're seeing in the Medi-Cal, Medicaid, and high Medicare. So if you look at our demographics of what we operate in the counties, we're 40 to 45% Medi-Cal. So it's a very high population base for us. So that's why we hit the list. It wouldn't be because of financial reasons. So what does that mean for us really? Are we a going concern in the county? Are we looking to go close hospitals? Are we concerned? Yes, we're concerned with the funding cuts, but no, we're not concerned about our longevity of being able to operate in the county. I will say this, last year we've done some great opportunities. When you talk about a business, usually there's 2 ways to improve a business. You grow revenue or you shrink expenses. We know our opportunity is to really grow, meaning we're able to go take more patients. So in collaboration, we talk about with Rod, we're looking at like, how do we make sure that we're moving patients in the right area, where we have the right funding sources so we not only keep the doors open that we have today, but we have the opportunity to continue to open more doors and continue to provide more access. If you look at the healthcare dynamic today, it's a tightening environment, right? You have costs that are continuing to be decreased on the revenue side from the feds and the state, and then you have assets that are very high cost. And so what you're seeing not only from our side, nonprofit healthcare, but even for-profit healthcare, we have a lot of them exiting the state. They're high asset costs and be able to continue to carry those things. So what we're looking for, how do you make sure that you're able to go continue to provide good patient care for counties? You do it, the easiest way to do it is usually through clinics, offering more, opening up the aperture to be able to do that. So we've actually talked and met with actually the school district locally to talk about how we can open up additional opportunities, create clinics that are dedicated to make sure that we can get patients seen, and not only seen, but seen quickly. So that's where we work with the FQHC, not only to be able to do that on their end, but collaborate whenever they have patients. So if they do need to roll through the hospital, we have care coordination throughout. And the other person I actually want to introduce you, I know Richard wasn't able to join us at the last meeting, but I'd love to actually introduce Richard Ryder. Richard has extensive experience in this space. Richard joins us actually from Seattle with 12 years, 15 years of experience in working in funding in the federal side?
At least, yeah.
Yeah. So Richard's done actually a great job of diving into like, what does it mean for us? So Richard, would you mind just kind of sharing what you've seen through the bill and what you anticipate not only in 2026, but the next few years as well?
Sure, yeah, happy to. Yeah, great to meet all of you and great to be here. You know, I think we've talked a lot about the impacts on our patients and our communities. So I'm not going to necessarily talk about that part anymore. I think we do have some opportunities on the grant side of things that hasn't been talked about. There's a Rural Health Transformation Fund. Is that something you guys have gotten involved in at all? Good. So, yeah, so there was an announcement made just before the new year. California got awarded $233 million. So we think we do have opportunities there to get funds that can help this community. So we're working with HCI, which is the lead organization in this state, to identify kind of what programs we can work on that would qualify for those funds. And some of those may well involve other organizations here in our community as well, like you're seeing in front of you today.
If you guys are done, we'll move on to Buck from Partnership Health Plan.
Thank you. And thank you all for having me today. As mentioned, Buck Ellingson, Associate Director of Government Affairs at Partnership Health Plan. So one of the things that we're paying attention to right now is the state budget. It was dropped last week by the governor. He had his Department of Finance chair present the budget, which is a little peculiar, but things didn't stop there. The governor came in with a pretty rosy picture of what we expect to see in 2026 in terms of resources coming into the state or what the state budget looks like. He's projecting about a $3 billion budget deficit, which is about $14 billion lower than what the Legislative Analyst Office is expecting. We have these two competing narratives that the budget outlook isn't so bad, $3 billion versus $18 billion. Both organizations are acknowledging about a $22 billion budget deficit in 27-28. So ultimately what we're looking at is just kind of more budget uncertainty as we move into 2026. The governor is really, he's looking to make more concrete decisions and forecasting during the May revise, which is in May, and then we'll have a final budget in June. So all of that's to say, we don't really have a clear line of sight of what to expect and what's coming, which is unfortunate because typically the January budget kind of gives us the path forward and helps us understand what we're dealing with. In terms of what the state is, what we know we'll continue to deal with is the HR 1 implementation. So in terms of HR 1, 2025 was really a shock to the system. Everybody was just trying to grapple with what exactly this means, who's going to be impacted, and where and when. 2026 is we're starting to see some of this play out. We've heard that the managed care organization tax may be funded through the calendar year 2026, but it may be ended as early as June of this year. When that happens, it's going to be fewer resources to the state that are then turned over to programs like all of yours. So we will see funding declines in 2026. It's just a matter of when. The governor's budget acknowledges about 400,000 Medi-Cal members will be disenrolled this year. That is about 3.5% of the total Medi-Cal population. I'm not sure exactly what it means. I think somebody said it was, I'm not sure exactly what it means for Mendocino County, but it's a significantly smaller decline than we initially expected. They've also revised their disenrollments down from about 3 million to 1.8 million. So that's some good news. We know that Medi-Cal, keeping people enrolled in Medi-Cal is really the lifeblood of rural healthcare. Without those paying customers at FQHCs and hospitals, hospitals and FQHCs are left to pick up the bill through uncompensated care. So my intention today was to come here and really just, I know that the folks from your HHS department spoke earlier, but I think it is a critical time right now to be in touch with your local electeds, your assembly members and your state senators, help them understand how badly rural counties like Mendocino are going to be affected by these changes. Help them understand the resources that you're going to need for your enrollment and eligibility specialists at the county offices. And that will be the best really that you can do to preserve the healthcare footprint that exists now. If we see significant declines in rural California, hospitals are going to be impacted. FQHCs are going to be impacted. People are still going to show up for care. It's just not going to be covered. It's going to go through uncompensated care. You have enough of that, and you start seeing hospitals start declining the services that they provide, the types of services. And then we're also starting to see closures across the state, even before these things start to take have a big impact. So the real impacts are coming in 2027. So we know in 2027, January work requirements are going to go into effect. We're also going to see the redeterminations double from once a year to every 6 months. So that's why I'm really stressing that the enrollment and eligibility offices need to be ready. They need to be staffed because what's going to happen is their workload isn't just going to double, but it'll probably triple because they're going to have twice as many redeterminations to do, but then they're also going to have to figure out how to integrate work requirements into their workload. So they're going to be busy, much busier than they've probably ever been before, and there's going to be a lot of figuring out how this stuff works. Beyond that, the population who's likely going to take the biggest impacts is those folks with unsatisfactory immigration status. As you all know, they're no longer eligible for full scope Medi-Cal. Work requirements will apply to the UIS population. In October of this year, the FMAP for emergency service to UIS populations will drop from 90% to 50%, which is going to be a significant hit to the state budget. And then we'll see UIS premiums begin in 2027. So lots happening in that space. And then I don't know if I touched on the MCO tax, but there's optimism that we'll continue to receive these resources through the end of the year. But with there's also a lot of uncertainty. I think that we heard today that the federal government doesn't work on anybody's timeline. They announce things kind of on their own and when they see fit. And so they may end our MCO tax revenue in the middle of the year. Hard to say. Unfortunately, the January budget doesn't address any plans to for the newly uninsured. It didn't speak to folks coming off of Medi-Cal rolls at all, nor does it speak to how to address the pending administrative burdens for work requirements and 6-month redeterminations. So if I were a member of the board, I would be in the Capitol, be working with CSAC, any of your associations, shouting at the top of your lungs about the importance of providing administrative resources to the counties. That's going to keep your hospitals and your FQHCs paid. If we see hospital closures, that's going to have huge ripple effects across the economy. You're not only going to lose the high-paying jobs that are in your communities, you're going to lose the contracts that folks that are associated with the hospitals. You know, all of the restaurants and everything that folks eat at, everything's going to be affected, and it's going to lead to declining rural communities. So, can't stress that enough. I know I'm talking a lot. Just wanted to say partnerships response. We've been tracking and monitoring and reporting on HR1 since the beginning. We also have a Keep Your Medi-Cal campaign. We also have a Keep Your Medi-Cal toolkit that anybody has access to, free of any partnership branding. It's ready for you to help cut the noise down for your members to understand what the process is like. We're also working on some lunch and learns to build relationships with our lawmakers and inform them about the rural health perspective. You guys all know that California is the population is very focused in Southern California and in Los Angeles and San Diego, which means that they have a lot of representation in the legislature. Our northern rural counties, not so much. And so we got to be in the room, speaking up, helping people understand that you can't abandon rural California, that we matter just as much as more populated areas of the state. We're also working with other stakeholders. We attended and spoke at a Assembly Health Roundtable a few weeks ago, and we did a rural hospital convening, which I'm sure you guys were at. So that's my remarks. If you have any questions, I'm here. Thank you.
Chair, if I
Yes,
may.
please.
Thank you for that break in there about getting with your legislation. We were very fortunate that Shaw and Yoder reached out to both myself and Supervisor Klein, and we do have that meeting tomorrow about HR1 impacts in this community. We also have a separate meeting regarding our state audit as well tomorrow.
Thank you. Supervisor Klein?
Yeah, I want to thank the panelists for their comments today, particularly the rural perspective. It's refreshing to hear your understanding of that from someone out of Sacramento, so thank you. My question is for CEO Antle. Would it be possible for us to put together a snapshot as these things are emerging, the information about the impact to Mendocino County as a tool for our advocacy in Sacramento.
Certainly.
Thank you.
Supervisor Williams?
Yeah, if we could go back to Jeff Mock. Is it okay if I ask a question about Coast Hospital?
About what?
Coast Hospital?
Absolutely. Yeah.
So I've been relieved that the healthcare district has been able to put together a plan for the seismic upgrade that will allow that hospital to stay open post 2030, maybe a few years later with the extension. But I see that they've also been working on a modernization plan, and the hope would be long-term financial viability for the operator and for the district, and maybe enhanced services that the public can receive. But I know they haven't been able to find a lender due to Adventist Health being the operator with a contract where they're able to leave periodically, right? So it doesn't have the long-term assurance that the revenue stream will continue to pay the note. Is there any public-private partnership that might allow that deal to complete?
Great question. So to add some context, that you're right. So if they're looking for private funding to be able to go fund the hospital, which has to do with seismic issues, if they're able to do that, the lease does state that every 2 years that as Adventist Health as the operator, we have some optionality in there. And that's the concern. And so as we've been actually working with their board of directors to understand how do we make sure we make adjustments to the lease, where there's some, I'll say, teeth to that, where the private investments could be able to come in and be able to make the funding. Richard and I actually met with the district, was it 6 weeks ago, 8 weeks ago? To talk, was that?
Yeah, something like that.
Yeah. So we're looking to make sure that we address it. We have no intention to be able to go leave. We want to make sure there's some optionality if the dynamics within healthcare, the state or the feds make significant changes. Adventist Health obviously wants to have some recourse there, but we want to make sure that we are invested in there for the long term. So we're exploring what language we can put in there that obviously satisfies some of that private funding so that makes sure it's there and secure, that Adventist Health is the operator and the district is there to support not only the hospital, but greater healthcare needs within the Fort Bragg community.
Excellent, thank you.
Yeah, and what I would add to that also is, the approach we're taking very deliberately is making sure we focus on the seismic requirements first, and then we can look at the additional kind of augmentation beyond that. So I think, we want to kind of have a very deliberate approach to make sure it's sustainable in the future.
Okay, I'm not seeing any more questions. Supervisor Haschek.
Yeah, just on that note, and I have no idea what that might entail for this private funding for the hospital modernization, but one idea is we do have this MSERA, which has over $800 million in assets right now. And I think that some of that investment should go locally so that we can do some of these improvements and still be have a fiduciary responsibility to the people who are in that plan. But I think that could be a win-win.
Okay. I don't see any more questions from the board.
Do you want to check with the public and
Yep.
online?
Anybody in the room? Yes, please.
Good afternoon, Camille Schrader. I have a question and a comment. So for partnership, do you have an estimate of how many of the Medi-Cal lives you see being reduced January 1st, of course, but then ongoing as this rolls out? The percentage of your lives that...
As far as partnership, no, we got these numbers last week. I think it was Friday of last week. Those were updated from January or July of last year. So we're still doing an analysis on what the outlook is.
For partnership specific, because those numbers were Medi-Cal general, not partnership specific.
Correct, yeah.
Okay, would be good to know that. And then around the Rural Transformation Health Grant, I was on a call last week. We met with the administrator overseeing that grant and really encouraged them to think about an algorithm that includes rural as a higher point margin in the algorithm than just rural generally, meaning that the 18 Northern California counties have 5% of the population, and yet San Bernardino has rural areas, LA has rural areas. There's other areas inside California called and defined as rural that will be competing for this money. So I'm hoping our board will be able to put something together in writing, something that says, we specifically want you to think about the way in which you put up, because they're creating the rules now for the HCI programs, the rollout, and the algorithm for rating. And there needs to be some consideration, much more. This is the first time we have an opportunity to actually be ahead of the game, right? Because we're rural for sure and frontier. So one thing. And then two, I know you said that you've been talking to HCI and you've looked at some things that may or may not include partners in the room. I think that I would suggest and hope that we would work as a collaborative to put together a county application on behalf of, because one of the things, Lucretia, I think is this was strategically, it may be that the rural transformation grant backfills a certain amount of, not Matt, because that's an ideological problem, but programmatically, I think there might be some strategy that's meant to actually not hurt clinics, but I do think it means we all need to understand the grant really well and not meet in silos around how we're going to respond for Mendocino County. So I'd love to be, I'm on the board of the hospital, and of course I love Mendocino County with all my heart, so if I can be of any help or support, I would absolutely love to. So that's all. Thank you.
Thank you. Anyone else in the room? Madam Clerk?
Sorry, give me 1 second. I'm struggling a little bit. Okay, seeing no further comment online.
Thank you.
Thank you all for coming today. Very helpful. Clerk Lilly, do we have CMSP on Zoom?
I am not seeing the presenters I was given at this time.
Okay, Chair, if you want to take a couple-minute break,
Yeah, let's take 10 minutes.
we'll reach out and make sure they can get on.
Yeah. 10 minutes enough?
Yeah.
Thank you.
I'll get you back on schedule.
Yeah. Thank you. We are going to jump into services program is,
Hello, can you hear me?
yes.
All right. Hello, everyone. My name is Carrie Brownstein, and I am the Executive Director here at CMSP. I think we are on at 2:30, and so Allison Kellen from my team was planning to join at 2:30. So just hang on one sec. Let me sure she's getting on. All right. Well, I'll go ahead and get started and she'll jump in. So let's go to the next slide. So my name is Carrie Brownstein, and again, I'm the Executive Director here at the County Medical Services Program. And Allison Kellen is going to be joining us. She's our Senior Director of Programs. I have been at CMSP for 20 years now, and Allison has been here, I'm just going to say longer, so longer than me, 25 plus years. Next slide. So what we wanted to do today is give you a background about CMSP. You might, some of you might be aware of what CMSP is and some of you might not. So let's just talk about it a little bit. It goes way back. So back in 1982, California law eliminated Medi-Cal eligibility for the medically indigent adults, and they became the county responsibility under WIC Section 17,000. I'm going to talk more about WIC Section 17,000 in another slide. So in '83, CMSP was established. At that time, it was a state program run by the California Department of Health Services. It's a pooled risk health benefit program. There are 39 eligible counties with populations of 300,000 or less at that time. And we have currently 35 participating counties, and we'll show you those counties on another slide as well. How are we funded? So back in 1991, health realignment was established as the funding method, funding for CMSP counties and CMSP program. In '95, the governing board was established. As a local public agency with overall program and fiscal responsibility for CMSP, we have our own statute. It's on our website, WIC Section 16809. In 2014, something big happened. It was called the Affordable Care Act. So you're probably all familiar with that. So with the Affordable Care Act, we had a significant decrease to our CMSP membership because those folks were moved over to Medi-Cal. And what the board did was then create other programs, Path to Health, Connect to Care, and additional grant programs. As far as our revenues, the health realignment that CMSP received directly from the counties, which was set up in our statute, it's the same amount every year since our statute, that was redirected entirely to the state. And most of the CMSP program realignment, we'd had our own realignment, went back to the state. In 2019, all of our health realignment was redirected back to the state. Next slide. Okay, let's talk about WIC Code Section 17,000 and CMSP. So Section 17,000 was enacted in 1937. It established the county's duty to relieve and support the indigent poor, and serves as the legal foundation for county indigent care obligations as the provider of last resort. It does limit the county responsibility to those legally resident therein, which does not include undocumented persons. And while counties have broad discretion in setting standards, they must provide medically necessary care. So CMSP and the other counties that do not have CMSP, we are not considered a coverage program. We don't have to provide all the services that Medi-Cal provides. We need to provide medically necessary care that is sufficient to remedy substantial pain and infection. Currently and in the past, we have looked more like Medi-Cal, but we'll go into later some federal reductions that are happening and what the board is going to be, they're going to have to think about going forward. The county obligation does not apply to mental health care. And although CMSP participation supports counties in meeting their Section 17,000 obligation, it does not relieve the counties of these responsibilities. Next slide. All right, I'm going to turn it over to Allison.
Good afternoon. I'm Allison Cullen. I'm the Senior Program Director here at CMSP. So as Carrie mentioned, we've got a variety of counties that participate in our program. There were originally 32 CMSP counties. Lake and Mendocino counties joined CMSP in the 1990s as part of the tobacco tax settlement. We were able to bring funds in and join the program. We added Yolo County right before the Affordable Care Act started. And there are 4 additional counties that are eligible to join. Those are Merced, Placer, San Luis Obispo, and Santa Cruz. Participating counties were based on a population size back in the 1983 of 300,000 or less. Some of those counties have grown substantially since then. Next slide. The board is administered by a governing board, which is comprised of a variety of county sizes. We've got our smaller counties, mid-sized counties, and larger counties represented, as well as a variety of roles within county government. We've got a county board of supervisors on the board, health executives, social services executives, and county executives. Additionally, there is a representative from the California Health and Human Services Agency who is a non-voting member to the board. So we don't currently have anyone from Mendocino County on the board. In the past, Carol Mordhorst served on the board for many years and was chair of the board, as well as Carmel, who was a former CAO from Mendocino County. Next slide. Talk a little bit about kind of the economies of scale, about how this program is administered and has benefited the counties over the years. We have a centralized county administrative office, which provides support to the governing board. We're tasked with overseeing the policy, budget, program administration, grants, and the variety of contracts. We're based in Sacramento, but again, we serve all 35 CMSP counties. We've got program-wide eligibility rules for both the CMSP program and our Connect to Care program. So a single county doesn't kind of pick and choose which benefits they want to cover. They are decided as a group with the governing board making the final decisions on those. We contract with the Department of Healthcare Services for CMSP enrollment using the county social services departments. They use the eligibility system CalSAWS and the Medi-Cal eligibility data system, which is MEDS, to make people eligible for the program. And additionally, we have a contract with Redmayne, which allows for CMSP and Connect to Care enrollment through participating health centers. And I do want to give kudos to Mendocino Community Health Centers. They're a very active enrollment site for our program. In terms of enrollment, we pulled the fiscal year 24-25 enrollment for Mendocino County. For monthly eligibility for both CMSP and Connect to Care, it's a little less than 200 members per month. When you look at the time period prior to the implementation of the Affordable Care Act, enrollment in CMSP and Mendocino County was more like 3,100 members per month. Additionally, it's kind of that economy of scale. We have got program-wide covered benefits for CMSP and Connect Care, and I'll go over those in a couple slides. We contract with Advanced Medical Management for our medical and dental benefit administration. So they handle things like claims processing, authorization of services, and working with CMSP to develop our provider network. We've got contract with Med Impact, which is our pharmacy benefit administrator. They handle contracting with retail pharmacy locations, individual pharmacy locations, and they handle the claims and authorizations for any of the medications that are covered under the program. Kind of core to the program, we do have provider contracts between CMSP and healthcare providers. Some of the contracted providers within Mendocino County include Anderson Valley Health Center, We've got their Adventist Health at their Ukiah Valley and Howard Memorial sites, Consolidated Tribal Health, Long Valley, Mendocino Coast, and as I mentioned earlier, Mendocino Community Health Clinics. Next slide. In addition to providing the covered benefits and enrollment functions, the board, since the Affordable Care Act, has funded a variety of funding efforts really focused on strengthening the provision of healthcare services within our counties. They established the Building the Healthcare Workforce grant recently and awarded Mendocino Community Health Center clinics almost $750,000 to grow the workforce within Mendocino and Lake counties. Additionally, your county Office of Education was also awarded a Building the Healthcare Workforce grant in the amount of $450,000, really looking at those ancillary types of services to help provide additional services within your community. The board has funded 2 workforce development grants, which provide loan repayment programs for educational debt for providers that are willing to serve within a CMSP county at a contracted provider location. Those can include things like physicians, dentists. They also do include things like allied health program providers, medical assistants, dental assistants, etc. Those loan amounts go between $16,000 and $50,000, and to date, there's been 11 awards within Mendocino County. Next slide. We wanted to provide you with a little bit of what the program looked like before the Affordable Care Act and what it currently looks like. As you guys have probably discussed already in this health summit, there's lots of things that are changing right now at the federal level in terms of who maybe continue to be covered under Cover California and under the Medi-Cal expansion for adults. And so our board's going to be taking a look at these eligibility requirements and the set of covered benefits. But we wanted to give you on the right-hand side, you'll see currently the programs serving adults 21 through 64. Their incomes are above the Magi Medi-Cal income level. So they're typically above 138%. There are a couple exceptions for certain income deductions, and they're up to 300% of the federal poverty level. The board had increased our asset limit to about $20,000 for individuals and $30,000 for a couple. Current enrollment can happen through the county social services departments and through the participating health centers that you're using the MK system. In terms of those, you can see on the left-hand side for those things, the income before ACA implementation didn't change. The income limit, though, was lower. It was only up to 300 or 200% of the federal poverty level. The asset test was also lower, and enrollment only occurred through county social services departments. Additionally, the enrollment terms were lower prior to the ACA, between 2 and 3 months of term, and then someone needed to reapply. Currently, we're up to 6 months of eligibility. There's a thing called share of cost, SOC, that you'll see. It's a monthly amount that a person must pay or obligate in order to receive additional coverage or for any type of claim that may have happened. And so the board, after the ACA, had kind of increased that amount of when someone does not have to pay their share of cost up to 138% of the federal poverty level. In addition, the board did a kind of a discount, a coupon based on the share of cost amount. So if it was calculated out to be $100,000, excuse me, $1,000, it's more realistic, $1,000 per month. And that 75% reduction would go into play. So the share of cost amount would be only $250 per month. That's amount that can be paid or obligated to be paid to a provider. So someone could say, I'm going to go ahead and pay the hospital $50 for the next 5 months, and that would be fine. Currently, there is no citizenship requirement. The person needs to just be they need to prove that they are a resident within one of the participating CMSP counties. Prior to the Affordable Care Act, we had kind of a bifold eligibility where we had full scope coverage to people that were verified citizens, and we offered an emergency services only benefit to those that were undocumented. Currently, as Carrie said, our program mirrors a lot of what Medi-Cal looks like in terms of CMSP coverage for emergency, urgent care, primary care services, medical, dental, vision, chiropractic, and behavioral health services. And we have a no-cost primary care and basic health care benefit that's built into CMSP and also to the Connect to Care program. Next slide. I'm going to turn it over to Carrie to talk about revenues.
All right. So here we also wanted to give you a picture of pre-ACA and more current. You can see those revenues pre-ACA. We had our county realignment, our own CMSP realignment, county participation fees, which I'll get into in the next couple of slides, and other. Currently, no realignment. Participation fees have been waived since ACA, and only our other revenue, which is made up of mostly interest. And you can see our enrollment for those years as well. Pre-ACA, I just want to let everybody know we were closer to 80,000 members. So about here, and what I'm showing you in 10-11, about 62,000 members and about 7,000 members in 23-24. One revenue to point out that's not listed is the county risk allocation. So every county has a participation agreement with CMSP. And what happens if CMSP is providing services and doesn't have the revenue to cover those services for those members, there's a county risk allocation. And the history I've known, that's only happened twice. It was pre-me. In the late 1990s, 99 and 2000, I believe. So that hasn't happened, but that's something that counties need to think about moving into the next few years with the federal reductions. Next slide. Okay, county participation fees, which have been waived. Just wanted to let you know what the Mendocino County participation fee that is in our statute has never changed. It's the same amount every year. So there's Mendocino counties. Next slide. We're just giving everybody's here. All right, next slide. And I'm going to talk about expenditures, 10-11 versus 23-24. So pre and post ACA. So you can see the big medical and pharmacy because that was our core. That was our core back pre-ACA. But then you can see we got into more grant programs because our benefit programs weren't as big. County Eligibility Administration, I want to point that out. Similar to Medi-Cal, we pay the counties an eligibility admin amount. So then you also have other, and again, you can see the enrollment. Next slide. All right, let's talk about the federal reductions. Next slide. Okay, so CMSP did some estimating, and this is as of December. Now, we all know the state budget came out last week, and there's some new estimates, and we'll be revising these estimates over the next week or two. But this is what it looks like as of December. And we've footnoted away how we got our numbers there. So not HR1, but federal is the covered California subsidy losses. So since we go up to 300% of the FPL, covered California could become unaffordable for some folks. And when that happens, they could come over to the CMSP program as we currently go up to 300% of the FPL. Medi-Cal work requirements. In December, what we calculated as a possible number of folks that could come over to CMSP if they fell off Medi-Cal, and you can see that number is over 75,000. Then we have some estimates there about the restrictions on lawfully present immigrants, and we're still fleshing those out, but this is what it looked like in December. We also did some PMPM calculations pre-ACA, looking at our costs, our medical inflation, provider rate increases, what these numbers would entail, and it could be over $800 million if all these folks came on to CMSP. But you saw there that our revenue doesn't support that. So that gets us into, let's go to the next slide. So the governing board is going to be having to think about some changes. So let's go to the next slide. So the board has been looking at these things, and all the things that they did between ACA and current, waiving our participation fees, provider and hospital rate increases. We did some marketing and media expenses. We launched Connect to Care. We launched CMSP and MCASE. Next slide. Then Allison talked about all these things in eligibility, where we increased our income limit. We increased our asset test. We did a reduction to our share of cost. We also, our retroactive coverage went from 10 days to 1 month. We increased enrollment terms. Next slide. And then we increased benefits as well. So you can see some different things where selected primary care and pharmacy services are offered without a share of cost. We added chiropractic services and lots of other additional benefits. Next slide. We also launched lots of grants, and then our scholarships and loan repayments. So we had our Lichen grant, we have our HID grant, a Healthcare Infrastructure Development Matching Grant, the Building the Healthcare Workforce Grant, loan repayments, and again, scholarships. Next slide. So the board is going to be considering in January and probably taking items to our Planning and Benefits Committee in February and making some decisions by March about our program, again, going back to those revenues and our anticipated expenditures. These are the things, all these things that we've talked about that they're going to be looking at, and what changes do we need to make. One thing to point out, eligibility changes have to happen in CalSAWS, and CalSAWS changes can take a long time. Some of the folks in your county are going to know about that. Sometimes those can take a year, and so those work requirements are starting January 2027, and so we're already a little bit behind because we don't know if these changes could be made by January 2027. Happily, we have a fund balance right now. We have a fund balance of about $300 million, and when I said our realignment was redirected to the state, there was written into the law that if we get down to 2 years operating costs, that we can get our share back, which would equate to about $50 million. So the board's going to be making all of these decisions, talking about these things, trying to make our program fit, because all of our board are from counties and don't want to put additional pressures on the counties. We are, along with RCRC, CSAC, CHIAC, UCC, CAPH, we are down at the Capitol. We're talking to the state about folks falling off Medi-Cal, how our realignment was redirected when ACA happened, and future revenue. We need future revenue to able to sustain our county indigent programs, not just the CMSP counties, but all of the California counties need this help. So again, these are the policy considerations, those eligibility ones we talked about, the benefit ones. Next slide. Some of our scholarships, grants, loan repayments, and also our budget items that the board will be talking about. Next slide. All right, that is the end of our presentation. I'd like to open it up for questions.
Supervisor Klein?
Yeah. To have you see earlier this, so that I'm going to have the stating the of January, March for some. Could you for specific
county participation item that we would take to the board in May for the next fiscal year? The board may or may not decide to reinstate that for 26, 27, since we have a fund balance. They're going to have to take everything into consideration. So it could be for the next fiscal year. They'll be deciding that likely in May during our budget talks.
Okay, thank you. And can you share a little bit more about with the moving away from CMSP, the board will be considering to the state?
Right now, so the group that I mentioned, CSAC, RCRC, CHIAC, UCC, CAPH, we've been meeting with folks down at the Capitol and with the state, Department of Finance, LAO, Governor's Office, trying to educate, and there's no particular ask right now. We're educating and we're talking.
Okay, thank you.
I'm not seeing any more questions from the board. Thank you. Appreciate you being here.
Thank you.
Thank you.
We do have another break scheduled, 10-minute break at 2. Did you want to? Yep. 5. to our last presenter, Dr. Robert Marbut, doctor, and thank you for being here.
Day. I'm not sure it's the end of an 8-hour day. Didn't you go yesterday? Oh.
I was hoping you'd be able to give nation, if you can, situation. And then I've got a couple other questions. I can give them to you now and then repeat them if you need me to. But what would be your professional opinion on which programs are more successful getting people out of homelessness and keeping them out? I know you documented it in your in the No Address documentary, but I don't imagine everybody's seen that. So if you could touch on those, and then also when we're talking about being successful, if the federal government has a standard for success?
Okay. So why don't I just jump in? I'll try to keep this to, I'm out on the wharf here because we've been in meetings all day, so I'm going to try to keep it quick and then let you direct the questions. That way you can cover really what you want to hit. But in terms of perspective, the national trends are, and I'm going to sort of set up the history because I think it's very important to understand sort of how we got here. I went to the Claremont Colleges in Southern California, and I went to the Peter Drucker that got a master's there while he was still alive. And he always talked about you got to know your problem to understand what you got to solve it. It too often, if you go to a workshop, a group of people, a continuum care meeting, and you say, "What's your problem?" People will always raise and tell me what the solution is. I'm like, we'll get to the solution here in a sec, but let's talk about the problem. How did we get here? And so I'm going to demarcate it in a few chunks of time and start in 2007 and go to 2013. I'm going to start with sort of the national trend, but to be real honest, California, Washington State, Oregon, to a lesser extent, Hawaii, is very similar to the national trends, just more exaggerated. So when there was an increase nationally, there was even a bigger increase in California, Oregon, and Washington. So all these trends go for California. It just more amplified version, like turning the volume up. So pre-2013, from 2007 to 2013, funding, federal funding included housing vouchers, but every single housing voucher in some form or another was tied to wraparound services in some form, even permanent supportive housing. The S in permanent supportive housing was supported, used to stand for supportive services. And so from 2007, and the reason I picked 2007, that's the earliest. There's really good, what's called AHAR, the annual report to Congress, and included the point in time. Pre that, there weren't really any reports with consistent number. There might be a report here and there. But in 2007, that became an annual thing you did for Congress. And so from 07 to 13, pretty much every housing voucher was tied some form or way to wraparound services. Federal funding was evenly distributed almost exactly in thirds. If you go look at the 07, 08, 09 annual report, it was almost exactly 1/3 emergency supportive, think of shelters, 1/3 for shelters, 1/3 for transitional housing, and 1/3 for permanent supportive housing. And it was really evenly divided 1/3, 1/3, 1/3. This is where the continuum care model really starts getting its legs. Everybody starts comparing it to a medical model. You go to an emergency room, and then you may go upstairs for a specialist, and then you go to some sort of recovery, outpatient, rehab. And so it was a very similar model. divided. And what's interesting from '07 to 13, homelessness in California and in the United States was pretty flat. And even some categories of homelessness were declining because there's a lot of different categories you can measure. You can measure street level, you can measure transitional, permanent supportive, unsheltered, total number, what have you. And I prefer to always focus on two numbers. What is the total number of homeless? Every single category. So no games. So you go permanent supportive, transitional, rapid rehousing, emergency shelter, and people literally living on the streets. Take all five of those categories together and put it in a number. And so from '07 to 13, when you had balanced continuum of cares, and when the federal government was funding services, it was slightly declining in most categories, and the few categories that weren't slightly declining was pretty flat. So it was pretty flat and down. Then in 2013, there was a move to create more vouchers. And so they cannibalized the wraparound services, took the money out of that, put it all into vouchers in the 2013 NOFO that came out. It also stopped funding any type of treatment at all, behavioral health, substance abuse, mental health, etc. And it started almost an immediate stop in emergency service funding. Think shelters. So where the federal government stopped doing shelters, and started the stopping of transitional housing. So as transitional contracts came up, they were discontinued. They were allowed to stay for a while. So the emergency service funding dropped instantly. Transitional housing took 2 or 3 years, and then it dropped. And all the money from all these different categories of savings were put into more vouchers for permanent supportive housing. But the very important thing happened also in that NOFO, which I think is really the precipitating fact of the increase, is it stopped funding wraparound services. So it said that's not important to us. And it said that service providers could no longer have treatment requirements. So unlike unemployment insurance, where in most states you have to go, when you're initially unemployed, you go to several classes, and then you have to keep searching for work, or TANF has requirements for the mom or the dad or the family, or I think Pell Grant, which I think is one that most people really understand, because it gives you a grant for a certain period of time, and then it says during that grant, you have to attend 88.5% of classes, you have to have a 2.0, and you have to show upward movement in your progression for that. That one has sort of been dropped. It's still on the books, but dropped. But everybody gets, you have to attend class and you have to have a GPA, or you lose your funding. And so in 2013, basically it became housing vouchers with no rules. Or if you want to be cynical, you could say it became a lot of Section 8 with no rules, literally no rules. There were more rules in Section 8 housing at that time than there were for the vouchers. In fact, people who had serious substance abuse would get a voucher ahead of everybody, but no treatment was tied to it. So major changes happened in 2013, and it unbalanced that one-third continuum of care. So what happens? Since 2013, homelessness has skyrocketed across all categories. Overall, homelessness is up 58% from during that time frame. Street level homelessness in many parts of America, mostly California, Oregon, Hawaii, Chicago, Atlanta, Seattle, Portland, etc. That street level homelessness is now doubling it's doubling every 3.8 to 4-5 years, depending on where you are. And street level homeless is the combination if you look at the HUD reports, it's the unsheltered number and the people in emergency facilities. So those groups we know go back and forth in a given month. They go back and forth. Nobody stays in one, moves to another. They bounce around. So if you look at that number is literally doubling 3, 4, 5 every years across many parts of the country. To me, the saddest one that has really come in since meth started it, but fentanyl in 29 really changed the homelessness situation. And now in California, the death rate has doubled in up and down California. The overall number is some counties are more than doubled. That in every county I've looked at is generally about 2 times higher death rate or more. And it's because people are being given a housing voucher without treatment and before recovery, and they go in and are using fentanyl and dying. So the death rate is doubling because of untreated fentanyl in most cases, not all, but in most cases. And all categories of homelessness are basically going up. There has been some shifting in parts of the country within the margin of error of more people moving into emergency shelters and off the street. Those numbers together actually have not reduced. So this has also added ancillary costs across the board. And this is why I love talking to counties, because cities have a police department. That's where they really see the call volume up with homelessness. But counties see it in multiple ways. They see it if you're doing the mental health authority or providing mental health direct services, if you're running a county hospital, if you are running the sheriff department, the jail, property values are dropping. All of that are negative factors that are tremendously hitting it. And I'll close and then open it up to questions here is what the President Trump did with the executive order over the summer is he has directed all funding programs in HUD, HHS through SAMHSA, VA, even places like Department of Transportation that have smaller grants for much smaller grant programs for homeless, is it says first and foremost, we're going to rebalance the continuum care. We want to get it balanced between a third emergency, third transitional, back when we had steady state or dropping. We want to fund treatment services and really focus on treatment and recovery. And this is what goes to your answer of what works. Treatment and recovery address the root causes of homelessness. And street level homelessness we now know with the largest study ever done by the Cal Policy Lab with UC Berkeley and UCLA is, sorry, got a call coming in here. That study showed that 75% of the street level, people literally living on the street, had substance use. Another 3/4 had mental illness. And to be blunt, sometimes people on the other side of the aisle, the conservative side, think that you start as a drug user and that's the answer. The reality is most of the people using drugs on the street was because of untreated mental illness. Not all, but there's about 6-7% of recreational drug use that ultimately becomes homelessness. But most of the drug use you see on the street is self-medicating from the untreated mental illness. And so if you don't treat that, you're never going to get ahead of this curve. The curve is just going to overwhelm you and then get to a point where you can't treat it. And then the last thing the executive order really focused on was really bringing participation requirements back and in saying that local agencies, when they provide services, they can have, if that's part of their best practice, we would like them to re-engage best practices. And so that might, like by far the best recovery treatment homeless program in America, that's just knocking it out of the park, is a faith group called Helping Up Mission in Baltimore, who is partnered with secular Johns Hopkins University, and they are just have a they have a out of town treatment program that comes in from Florida. So they fly from Florida up to Baltimore and are having a 70% success rate. 70%. No treatment has a program that has 70%. And what they have found is everybody has to be in a 40-hour program week. So they have to do at least 40 hours of activity, and some of that is job training, some of that's education, some of that's getting your GED, but 12 hours of that at least, and this is where the Johns Hopkins component comes in, has to be behavioral health, mental health, and substance use disorders. And they have found that if you provide an overall 40-hour week program, and their program runs 1 year, totally free to the participants. 12 hours of that, at the very least, for everybody in the program is mental health, behavioral health, and substance use. Now, some people with more acute situation will actually go upward to 25 to 30 hours of behavioral health and mental health treatment. So why don't we stop there, and I'll take questions, or if I missed some of the things you asked me to do, I can hit that too.
I'm not seeing any questions right now from the board, but we're struggling a little bit with our outreach programs here, and you know, I think we're going to head in the right direction and try and do something different, but maybe what is the standard of success? I mean, is there one? Does the federal government have? You know, I know it can't be 70%, but what is?
Yeah.
What does the federal government consider a program to be successful?
We have actually, we're about ready to bring a small work group in just to address this issue, and then to look at the interconnected point in time count and HMIS systems. Because to be real blunt, the last 4 years have measured two primary measurements: how fast a person gets a key to housing, not how good the housing is, not how sustainable the housing is, not any move toward independence, just how fast from when you met your case manager to when you get a key to your place. And they measured the total number of people. And the way I look at that is, we're not measuring the total number of people who exit homeless forever or become self-sufficient. We're measuring how fast we're growing the welfare system. That's the two main measurements the last 4 years: is how many people got on permanent supportive housing, subsidized government taxpayer housing, and how fast did each person get on it. And we're saying that's not a measurement. Our measurement should be, do you get to self-sufficiency? Can you rent your own apartment because you have a job? Do you have less arrests? Do you have less calls for service? Do you have less entries into the emergency room? Do you have less episodic episodes where a crisis team has to come out? So we're about ready to start looking at that and start trying to create some best practices around that. Now, a good treatment center, 70% is out of the world. That's a number that, I have no idea what Betty Ford Clinic does. I've never looked at private ones, or Sierra down in Phoenix, or some of those. But 70% is an amazing success rate. But what they have learned is they measure success by how many people move into market housing, how many can afford their own housing, and don't need government subsidies anymore, and how many people are getting jobs again and sustaining. If you get a job, that means you're showing up on time, you don't have a substance use disorder issue, or you're treating it. And so those are really good sort of measurements, or leading measurements, or proxy measurements for the overall homeless condition, rather than how many people you put on welfare.
Thank you. Supervisor Williams.
Is there another county, ideally in California, but is there a rural county we could look at as an example? Who's doing it best?
I don't know candidly of a lot of people in California. That's why you have California has. I haven't looked at this year's numbers; they're just coming in. But California historically has had about 40. Even though you're not 45% of the measurement of the country, you have 45% of the homeless problem, and so I don't know of any programs in California that are, to be blunt, really working.
What about West Coast? Broaden
Yeah.
it.
Yeah, same with, I mean, Portland is in deep trouble. Portland is probably past San Francisco. San Francisco is starting to turn the corner. They're starting to do some smart things. I don't know if it's changed their numbers yet, but they're starting to. Seattle is one of the cities now. They have 10,000 street level homeless now. They have the highest per capita homeless, and their homeless now is doubling every 3.8 years. And they doubled down on safe consumption, safe drug consumption sites. That seems to be their primary focus. Is we want to have everybody come do drugs at the same location, rather than saying we want to do everything you can not to drug.
Supervisor Klein.
Thanks for sharing your insights with us today. I'm hearing the focus on treatment, and I'm curious about your perspective on pulling folks into treatment when they're interested, willing, and able versus folks that aren't interested in treatment, and what is the federal government's view on bridging that gap?
I love this question, because this is such an important strategic question. I wish everybody everywhere I went asked this, and it's sort of there'd been a long history in the treatment community that said you need a willing person to take treatment for it to work or click. I mean, there's a lot of anecdotal information out like that. There's emerging anecdotal information that says the police officer picked me up, the judge gave me a choice of treatment or jail, and there's emerging, but that has not been scientifically studied yet. So it's purely anecdotal, so I would not sort of hang my hat on that. But let's take it, a mystery county, county XYZ. And let's say they have 800 people experience some level of homelessness. 400 of that is street level or emergency, the one that sort of is the call for services, the complaints to the electeds, overusing, misusing, the hospital. So let's say we got 400 people in a county, and we set up a treatment program that has 25 beds. I'm not worried about trying to get 400 people into treatment tonight. I'm worried about trying to make sure there's 25 people ready tonight who are ready and willing and are going to give treatment and recovery a good shot. Because if they say you don't hit 70%, you hit 40%, the math to reduce homelessness, and I know this sounds so simplistic, it's you need to have more people recovering in treatment than you have new people experiencing homelessness. And so if you only have like 25 new people coming into Mendocino experiencing homeless, domestic violence, post-traumatic stress, veteran, a new substance use, somebody. That means you need to be successfully treating 26 people a year. So I'm trying to get people to say, you don't need to focus on the 400. You need to focus on a large enough size that meaningful starts taking bites at the elephant or the apple, and you start getting people into treatment. And the key is for it to have a very high success level. Be patient about it, because if you can, like Haven for Hope in San Antonio, they're running about 68% success rate, and that's people with mental health issues, not non-mental health issues, substance use disorders, or none of the above. That's 68% for all categories. And what they're finding is it takes about 9 months of treatment on the average. So they're patient about it. And San Antonio has had a sustained 85% reduction for 15 years now. You're seeing similar numbers to that in West Tampa and Pinellas County, not East Tampa, but West Tampa. So everything Pasco County, Pinellas, there. And so the key is not say, and here's why let's pretend you have 400 people who really need acute medical, behavioral health, mental health, substance use. You would never build a place for 400, because what happens after the 1 year, and you have, even if you have a 40% success rate, 160 people are out, some people are recycling through or recidivizing through. Now you've overbuilt your place. So you never build to your top number. You build to a number that you can successfully sustain and be patient about it, where you have enough funding to be successful and do it right. As compared to, I only have this much peanut butter and I have 4 loaves of bread. So I'm going to spread the peanut butter so thin at 5 feet, it looks like peanut butter. But when you get at it, it's so thin, it's not meaningful. It's not a peanut butter sandwich. So if you have 400 people on the street, I think you need to set up a program that's like 50 beds, 75 beds, 85 beds that really works. And then 9 months from now, you get a whole new group of people in. And in reality, you get some people who recidivize this week, and then that opens up a bed and you bring people in. So the key is not thinking about how do I get 400 people in tonight. The key is how do I get 400 people in over a 3-year period. And so you start with the most willing, and then you work with the next person and the next person. I know that's a really long answer, but you asked a very thoughtful, real important question, so I wanted to hit it thoroughly.
No, I appreciate it. So if I could restate some of that to make sure that I'm understanding and folks listening in are also understanding. It's about creating the sustainable pipeline and bringing the people in who are willing and ready, and then continuing the pipeline.
That's way better than I said it. So
No,
there
no,
you
no.
go.
Thank you.
But you set up that pipeline, and so if it's 62 beds, and say you're averaging one person recidivizing out every 5 days, that means your outreach teams need to identify every month about 5 to 6 people who will come in next month. She's almost ready. Robert's almost ready. Jose's almost ready. Guadalupe is almost ready. And so if once you got your treatment facility full, you figure out what your recidivism rate, because even John Hopkins has recidivism, and so everybody's going to have a recidivism rate. So you figure what that is, and if it's 6 people a month, then we got to be ready in February to have 6 good candidates ready to go. They may not be ready today, but we got to help them get ready by then. And that's how you do your outreach team. That's how, do you enable hanging out on the street, or do you say we're no longer going to enable? And there's a term I heard up in Seattle that, you know, even in spite of Seattle being crazy and San Francisco being crazy, they both have some programs that work real well. In San Francisco, Lighthouse, it was Salvation Army, is an incredible program. But I heard a worker, and I wish I knew who it was because we went back and tried to find him to cite him, and we can't find him. But he said, he summed it up with so good, and he goes, compassion without accountability is enablement. And I firmly believe that. And so the outreach team needs to have that balance between compassion and accountability. Unfortunately, there's some people on one side of the aisle who wants to arrest their way out of homelessness. That will not work. Never work. Never, ever, ever will work. And then there are other people who says, you're experiencing homeless and you're a meth addict, you're a fentanyl addict, let me just give you some more fentanyl and I'll make sure it's not a dose that will kill you. And we keep you on the drug program. That's over compassion, that's enablement. And you need to be both. We love you so much, we don't want to let you stay where you are. We're going to do everything we can to help you, and we want you to get ready to be helped.
Thank you. Supervisor Mulhern.
Thank you for your presentation today. I appreciate that you mentioned the link between poverty, trauma, and self-medication that happens to many people that live on the streets throughout our country. In rural America, rural California is no different. We lack housing and we lack jobs. So what's the federal administration's thoughts around issuing more funds for workforce development? I understand your housing goals are not necessarily housing first focused, but with a serious lack of jobs to give even the most motivated person, what are rural Northern California counties supposed to do?
Well, I'm going to push back slightly. I agree with a lot of your setup there, but I'm going to push back a little bit. What we're finding in rural areas in like Pine Bluff, Arkansas, you know, which is population, I think, in Fort Smith, Arkansas, I think like 35,000, 45,000. They set up a one-stop center, and they've taken, they had about a 4-mile long encampment along the river that had about 600 people in it. And they may have on any given night 8, 9 campers out, and that's all they have. And they set up a one-stop program, very cost efficient, not elaborate, not over the top, but it's what they needed. And they are doing that. So they're as one person recidivized, they have another person ready to go. But what we know at street level homeless, and I'm not talking about domestic violence, I'm not talking about post-traumatic stress. Again, homeless is not homogeneous, but street level homeless, what you're seeing on the street, even if you give them a job, they won't sustain there. There's this really famous program that was done in Salt Lake City with the police department. They would come over, vouch for you so that the criminality background check did not keep you from a job. You know, the Obama check the box, if you remember that. And so the police chief, it was his personal pet project. He dedicated police officers to pick people up from the different homeless facilities, take them to their work, make sure they got there, gave them money for lunch, and then brought them back. How many people do you, as a percent, do you know how many people stayed at the job when he found them jobs? Less than 15%. They were not ready to go work because they had not worked in so long. They were the 8-hour day. They were like, I can't work 8 hours a day. I haven't done that in so long. And so it's not the jobs that's the problem with street level. I'm just talking street level homeless here. The problem is getting a person who can handle the job, because if you've been out in the street for 5 years and you don't have hygiene, you don't have clothes, you don't have your teeth in order, you don't have haircut, you're not going to make it on the job. So we got to get your job ready long before we're worried about what your job is.
Okay, I'm not seeing any more questions here, Doctor. I appreciate your time here today. Thank you very much, and thank you for what you're doing.
And I got to say, I looked at your agenda last night. I wish every county, every city, every region would be as serious as you all have been to do a 2-day rolling workshop with sort of the who's who of everybody related peripherally, directly. I can't believe that you all got everybody set up to do this. Just, I literally, if everybody else would do it, they would be doing much better than they are. So I'm excited for what you all have done.
Well, that was the executive office, so thank you to them.
Not everyone has a CEO, Antle.
That's right.
Yeah. Well, that I guarantee you, if you go look at 37 other county or 3250, whatever it is, the current county number is, I guarantee you, you're not seeing 2-day workshops with this level of people. I guarantee you that. So you should be proud of what you all have done.
Thank you, sir. Appreciate your time.
Thank you. Bye-bye.
Is there anybody in the room that would like to comment? Yes, Ms. Williams.
I can never tell if this is on. Jackie Williams, 4th Street Project. Thank you so much for that. To help answer your question, Supervisor Williams, a lot of the data and research on drug addiction and overcoming drug addiction is being collected by the Hazelden Company and the Betty Ford Company combined. And so they have a great website and usually have the latest. So that may be a resource. I know many of us in the field use them. But thank you. Thank you for this. The only question I had is the program he held up. I have heard of that, and there's a strong faith-based component to it. And just like you heard from priests today, that many of our folks that we serve have that need for that spirituality. And yet there's this kind of like, if you're a government providing services, you know, how does that work? So that may be one of those areas we can work through and get some clarity. Because I do think for some people, it's really important, and it's very much one of their sustainability.
Yeah, and I think
tools.
regardless of what, whether it's faith or a higher power or whatever it is,
yes, whatever
somebody needs something
your
to
belief
grasp
system
onto.
is, there is a place for that in the medicine wheel. So we can't, just because you're at a, I've literally had people ask me, but wasn't this building paid for by the state? Well, yeah, but the treatment includes this piece too. Yeah, thank you.
Thank you.
Mr. Marbett gone?
He is.
Okay, well, so I just had a couple questions, which is, assuming all of that, what does getting somebody ready mean? Like practically, how do we, engagement seems to be a necessary element of getting somebody ready and then having them be ready when the bed is empty. So there's this pre-work that needs to be done and they need to be somewhere while that pre-work, and what is it, first of all, from his, so I'd love that follow-up. What does the getting ready specifically mean practically? And then 2, treatment. So he spoke a lot about treatment, and certainly, for sure, the people on street level homeless need treatment of some sort, right? Whether it's addiction treatment, mental health treatment, some sort of getting ready to, the stories about not being able to hold a job because you haven't, held a job for 5 years is really true. As you know, long-term homelessness is pretty difficult to climb out of. And so how are we funding treatment if that is the second element? So what does that look like? Is it shelters? Is it treatment programs coming in? Like how will that be funded?
I'll ask him in
Those are
an
the
email
two
and
follow-up.
copy you on it.
Assuming all the rest, once happens, how do we do
Yeah.
that?
I'll send him an email and copy you on it.
Great, thank you.
Yeah. Anyone else in the room? Madam Clerk, anyone online?
We have one online, Peter McNamee.
An interesting discussion, but one that is a little puzzling because it seems like all of the discussion regarding the homeless was about what you do after people become homeless. And what didn't get discussed at all is what does society do to prevent people from becoming homeless in the first place? And wouldn't that be a much better investment of resources for the county to explore? Unless you have reason to believe that a large number of people who are homeless in Mendocino are coming from outside the county. And I don't know, I'm not an expert on homeless, but do you know where these homeless people are coming from? If they're coming from outside the county, that's a different kind of issue. But if they're genuinely natives of Mendocino County, then have you answered the question of why they are becoming homeless and how you might prevent that from happening? And if you are trying to prevent it from happening, how could you do that better so that you have less homeless to deal with? Listening to the prescription for what you do for people who are homeless in long-term homeless situation, that's a really expensive process. There's just no question about the fact that it's going to cost a lot of money to correct a situation after it has become out of control. You know, the old adage of prevention being worth a lot more than cure seems to me to have been lost in the message and discussion today. But thank you very much.
Thank you. Madam Clerk, anyone else?
Seeing no further comment online.
Okay, we'll bring it back. We have one last item, just debrief and wrap up. Ms. Hantel, I believe you have
Yes.
a list for us.
Yes. So first, I would like to talk about today. There's very limited stuff that we took away from today, but to confirm, one, it was the request for an HR1 impact fact sheet, which we should be able to put together fairly quickly. Two was around the EMS discussion this morning. And that's kind of broken down into a couple of different tasks, I believe. One, we need to determine what is the amount that is needed for EMS services, meaning the ambulance services. We know LAFCO is working on fire surveys, so we need to check in with them and see where they're at. Look into property tax and or parcel tax, and look into polling for a tax, sales tax, whatever type of tax for EMS services. And I have that. I don't know we can get the polling and everything done, but I have it for an update in May. Does that sound like the takeaways for today?
I think you captured everything on my list. For clarity on the EMS, just because for so many years, more than a decade, the county has had false starts where we begin down a let's scope it out and it doesn't go anywhere.
Right.
One supervisor thinks the way to do it is take every dwelling in the county and map it to a receiving facility. Bernie's house to Coast Hospital, figure out where he'll go, what ambulance is responsible, what does that service need overall to cover the gap, to have enough paramedics, enough units in the field with backup. What's the parcel tax that would get us there? And then do the same thing for Madeline, right? Work every house around the county, where would somebody from that address be transported, and how much of a delta is there? What do we have to raise to cover it? This is one way to tangibly derive a number that's realistic and get to the bottom of it. Every attempt has been, talking about numbers so big the public says no. Or, you know, in an ideal world, if we were at Los Angeles, what kind of service would we have around the clock with 5-minute response times? We have to be realistic. What we want is basically what we have, just with some additional funding to make the services whole.
That'll require a bit of work, and I think I can get GIS to help me, but I would have to think about that a little bit. But I think it's something we can put on the list as well. So if we kind of agree with that, then I want to pull up, Miriam, can you pull up, we typed up the list from yesterday because it was a little more extensive than today. So if we could just pull that up quickly and go over that. I think we captured, I'm not going to read it all to you. I hope you can look through it within a couple of minutes, and then we'll move on to the last comments. I think you can scroll just a bit quicker. Oh. Agreement?
Yeah, board, Klein?
Just a comment on item number 3, and so I think that more work needs to be done on this. I'm not saying in this meeting at this point. Maybe that's the work for the ad hoc, but especially after today's conversation, the last session, I think that that can help inform some of the work for the ad hoc.
Yes, Supervisor Williams.
I have no idea what it means. I mean, we should do something there. We have a vision, what we want the outcome to be, but I have no idea what that path is. I mean, what I heard today is there's no working examples. And I think it's really hard for local government, even when there's a working example, to replicate it. It takes a long time, but to be nimble enough to not even know where the light is at the end of the tunnel. We're going somewhere. Let's do it, but we don't know what it is. It's kind of daunting. Is there an intermediate step of identifying what the strategy might be before we talk about how to implement it?
Are you talking about number 3?
I'm sorry, I was talking about the homelessness.
Yeah.
I don't. What are the numbers?
It's number 3. Yeah.
Oh yeah, homelessness. Yeah. Does that? I mean,
Yeah,
I'm curious how my colleagues feel about that. What are we asking staff to do exactly, besides make it better?
Well, I don't know that we're asking staff to do anything on this one other than, we put an ad hoc together and start meeting with staff.
To figure out what our goal is or how to.
I have a comment.
Yeah.
Please.
Yeah, I think that the goal of number 3 would be to continue developing the framework with the collaboration of the Sheriff's Office, Social Service, and Behavioral Health, and develop a framework for board consideration.
I like that.
You have something, Mulhern? No? Thought I saw your pen up. Supervisor Hesjack?
Yeah, going back to maybe number 2, which was the state audit. Let's see. Continue. There, stop. When you, at the bottom, the ACFR financial processes paused. And we talked about the Munis workflow, Aumentum, presentation, overall ACFR process. I think it should say paused pending the Ben Rosenfeld analysis. Because I think that that's what we're really looking for is how do we get these things that are noted in the state audit, and maybe Mr. Rosenfeld can help us with it. So I'm just saying, clarify that paused. Really do want those.
Something we didn't talk about on the state audit, my read told us, don't do these broiler dinners again. I don't know what to do with that. I don't want to be involved. I don't think the board should be involved. If the district attorney, he has some arguments, maybe he's right, maybe he's wrong, but that should be between the DA and the state. And I'm concerned some of what they told us not to do, if it happens again after they told us, am I responsible? Is it this board that's responsible for not setting policy?
As you know, we have a new council, and it's probably not up to full speed on that, but prior council is that we bring something back at a different meeting.
So is it safe to assume until we come up with a policy or we figure out what's allowable that such activities are paused?
They should be paused, yes.
Okay. I'm asking out of paranoia. Somebody's going to show up at one of these meetings and say, "Hey, this just happened, and we're responsible." So until we figure it out, I think those kind of transactions should be paused.
Yes, those meetings typically happen in towards the end of February. So hopefully we can have a discussion on February 3rd.
Okay, please.
But this pause is different than what you're talking about, right? This pause is that layout of the whole process that we talked about.
I think anything that the state audit highlights the county violating best practices, we should pause until we decide how to be compliant. And there may be some department heads may have arguments that they disagree with the report, and I don't know where that goes. But I think we should all agree to pause. We've been told don't do this, or it's a red flag the way you're operating. We should take note and halt such activities until council can review and guide us.
And the flip side, if I could add, is that if like the executive office is working towards compliance for some of those issues that were identified in the state audit, then they continue on.
Okay, Klein?
Just a general comment. I'm really happy with how our workshop went, and I think that this framework of our priorities for the year is very beneficial and will guide us well.
Yeah, and I just want to make sure everybody understands that this was the executive office that put this together. CEO Antle and Ms. Ramirez and Sarah Pierce, the responsible parties here. So thank you to all of you.
Well, thank you. Is it my turn now?
It is. Please
All
go
right.
ahead.
So I want to start with thanking the Board of Supervisors for the opportunity to serve as CEO. Some folks know when I came to the county after 22 years in healthcare, I was looking to slow down. Well, that didn't happen, but it's going to start that, I'm starting in that direction. I am publicly announcing my retirement, which will be effective the end of June of 2026. The opportunity to serve certainly been a wild ride over the last 8 years with the county. Several natural disasters, COVID, financial uncertainty. I'm pretty sure a lot of things that I faced, particularly in the last 3.5 years, not many CEOs ever meet that in their entire career. The successes have been many and rewarding. So now you're going to have to bear with me as I mention a few. Securing behavioral health jail wing funding, which is leading to the completion of that wing this spring. That adventure of going out for certificates of participation was difficult, but we managed through. Evidence storage relocation to a county-owned facility, which is a huge improvement from where our storage has been for evidence prior. Purchase Whitmore Lane during COVID for a safe place for folks to recover, which will soon be opened as a final goal of Measure B to a psychiatric health facility. Purchased a hotel during COVID, turned into Home Key with the magnificent oversight of Megan Van Sant. After years, we were able to connect with outside legal counsel to start relieving the county of surplus property. Upgrade to Munis system that was 7 versions behind. We were on the verge of not being supported for our financial system. Upgrade to our payroll system. Hired several department heads, public defender, APCO, social services, HR director, ag commissioner. They are so wonderful. I think we found some really good long-term individuals that will help move this county forward. Created health services and now putting EH back with public health. Normalized cannabis, finally, back into planning and building services. Worked through several financial audits, including from the state auditor and one from the state controller, which helped identify areas of improvement. 15 policies were rescinded, 3 new policies created, and 2 revised. We developed a grants division and implemented software for monitoring grants throughout the county. First time we set up and got up-to-date MOUs with Air Quality Management District and the University Extension Office. Increased financial transparency and training. Yes, Supervisor Williams, we got a long way to go on that. We downsized central services. We outsourced fleet maintenance services, putting dollars into private businesses. We installed vehicle trackers, which has reduced accidents. And again, this morning you heard how proud I was of PERM and OES and opening the EOC. I think that's been amazing. We also did the emergency operation plan, the hazard mitigation plan, and the fire mitigation plan. Relationships have been built, organizational behavior has developed, culture is changing, and we're breaking down silos between the departments. There's never enough, there's always more to do. I have to say it's been a joy working with the department heads, the board most of the time, especially my team. I feel this is a little full circle, as the woman who recruited me and encouraged me to join the county is now sitting next to me today. So if you're upset about the last 4 years, talk to Kit. Even if she left shortly after I started. So again, I want to thank everybody. It's been joyous, and I'm excited to be leaving, a little sad, you know, conflicting, a little emotion at this point, but it's been fun.
Thank you. Thank you for that. Yeah. Okay. I don't think we'll do public comment there, but it is 3:50 and we will adjourn.